All right. We are going to go ahead and call this meeting to order. Welcome to the Joint Labor, Health, and Social Services First Interim Committee meeting, and we will go ahead and start with roll call.
Good morning. This is roll call for the Joint Labor, Health, and Social Services Committee, May 14th, 2026. Senator Crum.
Present.
Senator Hutchings.
Here.
Senator Scott.
Here.
Senator Steinmetz.
Excused.
Representative Clouston.
Here.
Representative Guggenmoss.
Here.
Representative Heft.
Here.
Representative McCann. Representative Rodriguez-Williams. Representative Thayer.
Excused.
Representative Wasserberger.
Excused.
Here.
Nope, caught it. Kidding.
Representative Yin.
Here.
Co-Chairman Ottman.
Here.
Chairman Brennan.
Present.
You have a quorum.
All right. We're going to go ahead and start with just a couple of housekeeping items of just remembering decorum and the talking through the chair. I know most of you guys are well aware and do all these things. And then just respect. There are a lot of topics that come through here that are very personal, and we have a lot of feelings around them. And so just respectful of all of that type of a thing. And with that, we will go ahead and get started. We're going to start with the just an update on Rural Health Transformation Program with the Department of Health. And I'm not, are you going to do it? The director, unfortunately, isn't able to be with us today due to.
Yeah, he's on.
He is online. Okay. All right.
Chairman Brennan, can you hear me?
We can. Thank you.
Madam Chairman, Co-Chairman Ottman, members of the committee, Stephan Johansson with the Wyoming Department of Health. First of all, thank you for your accommodation. I've been quite ill this week, and rather than come up to Casper and spread this particular brand of love to you all on the committee, I appreciate you letting me join virtually this morning. You do have in person our Deputy Director, Franz Fuchs, and our Business Operations Administrator, a relatively new Senior Administrator in my office, Monique McBride, who I wanted to introduce you to as well. They'll be handling most of our presentations today. But I wanted to provide an update to the committee on where we stand with Wyoming's Rural Health Transformation Program. Madam Chairman, if I may, just a little bit of background for the committee as kind of a level set or a reminder of how we got here. The Rural Health Transformation Program is a new program that was authorized by HR 1 or the One Big Beautiful Bill Act. So a very large piece of federal legislation that President Trump signed into law on July 4th of last year. Included in that law were a lot of things that are definitely above my pay grade and outside of my expertise when it comes to the tax code and various provisions around income taxes and other areas. But within the health area, for all states, health departments, and especially Medicaid programs, there was a special provision known as the Rural Health Transformation Program that was newly established, and Congress appropriated $50 billion to this program. And the intent for the program was to both stabilize and transform and sustain rural and frontier healthcare around the country. And so what that looked like in terms of implementation was the Centers for Medicare and Medicaid Services were tasked with administering this program. That's CMS, and they ended up issuing their guidance for this program in mid-September of 2025. That guidance had a lot of different provisions in it, a lot of do's and don'ts, a lot of cans and cannots, but ultimately what it directed states to do was to submit applications by November 5th. We submitted our application for Wyoming on November 4th of last year. But I think it's important to remind the committee and mention Wyoming took somewhat of a unique approach in developing its application. Between mid-September and the end of October, we prioritized in-person public engagement so that we could hear from your constituents, from our constituents, on what the problems were, the challenges were, what their priorities were for rural and frontier health, and ultimately, if given the choice, how our public would elect or essentially opine on spending a relatively large amount of potential federal funds that we could be awarded. So in the month of September and bleeding into October, we held numerous in-person public town halls in rural communities across the state. I think we hit 9 or 10 communities. Again, it was a pretty compressed timeline, but we also held 3 virtual town hall meetings so that folks who weren't able to attend and provide their feedback could do that online. And ultimately, we structured those meetings in a way that allowed us to not only collect feedback on challenges, on priorities, on preferences on how to spend the money, but also some structured exercises where we could quantify those preferences and those priorities from the public. That information ultimately led to a statewide survey that we sent out that helped us further refine and quantify essentially the public's preferences on how they would direct the state or prefer the state to implement this program and spend these funds. We had about 1,300 responses to that online survey, which is really pretty good given the compressed timeline and how we were developing this program. And in addition to that public engagement, we also engaged with our provider groups, our various associations, our hospital association, our EMS association, our primary care association, and their various members, CEOs, et cetera, as well as our educational institutions, our university, our community colleges, and others. Again, in about a 2-month period, pretty compressed timeline, but I'm pleased with the amount of engagement that we had. And the real takeaway here for how this application was developed is that we really wanted to develop it from the bottom up. So avoiding the temptation for me and the health department to essentially pick the direction and the priorities for how this program would be administered, but really listening to and prioritizing the feedback from our public, our providers, and our stakeholders. So that was essentially the month of September and October. And as I mentioned, we submitted our application to CMS on November 4th of 2025. They had a review period, and per the Congressional Act, had to make award decisions by the end of December. They did that, and Wyoming received a year 1 award on or notice of award on December 29th of $205 million for the first year. I'll stop here and remind the committee that this, per HR 1, the Big Beautiful Bill Act, this is a 5-year program, the Rural Health Transformation Program. And so you can kind of extrapolate that year 1 award out, that if we were to receive a somewhat similar amount in years 2, 3, 4, and 5, then over this 5-year period, Wyoming would essentially be receiving just north of $1 billion in this rural health transformation program. Our award in Wyoming was the second highest per capita award in the country, just behind Alaska, which speaks to, I think, the quality of our application. So I have to thank Deputy Director Fuchs and our entire leadership team and staff here at the Department of Health for producing such a quality product that was scored very well by the federal government. But ultimately, gratitude to our public for engaging with us, and certainly our providers and our provider associations for their work in helping us craft this application. So now we get to the meat on the bones. What happened after our notice of award? During the month of January, when all states were essentially having to revise their budget proposals based on the award decisions by CMS, based on certain parameters, and also based on a deeper dive by the federal government for all states on what types of costs in their proposals would be allowable and what types of costs would not be allowable. And we started engaging with CMS approximately mid-January. And it resulted in a couple of disagreements between the state of Wyoming and the federal agency, CMS. And that really boiled down to two areas. As a brief reminder to the committee, our application and our initiatives that we proposed had several very innovative concepts in it. I will say, if you go to our website, you can see on our landing page the Rural Health Transformation Program link, and that'll take you to all of our documents, including our full application. For those of you who need a refresher, but also for the public who's listening in, you can go to health.wyo.gov, and right there on the landing page, you'll see Rural Health Transformation. But the entire application has a lot of innovation, a lot of creative concepts and initiatives within it. But the two biggest where I think Wyoming was innovative is, number one, in one of the big financing mechanisms that we had proposed that was, I think, creative and innovative, that was known as the Rural Health Transformation Perpetuity Fund. And that was something that we worked with the Joint Appropriations Committee and the Legislature on to establish a funding mechanism that would essentially allow us to spend less of our award over the short term, but also stretch those benefits out, those initiatives out, and that funding out over a much longer period of time. Again, known as the Rural Health Transformation Perpetuity Fund. That's the first innovation in our application I'd like to mention. The second is more structural within the design of Wyoming's plan, and that was quite simply the amount of our award that we had proposed to hit the ground directly to our smallest rural and frontier hospitals, our critical access hospitals, and secondly, to our emergency medical services, or EMS providers, those that provide the much needed ground ambulance services throughout the state. Wyoming had proposed that out of our total award, we would spend approximately half of it to those types of providers. And what would we get for it? We had proposed, in exchange for that funding, that in order to receive that funding, that those providers, our hospitals and our EMS providers, would participate in conservative, smart, and practical reforms or transformations to really reflect what we heard from the public. And I'll back up there and just reiterate how proud I was to be in Wyoming, and for the feedback and the input that we got from our public in those town hall meetings. Because when we came and said, hey, we have this opportunity, a lot of federal funding could potentially be on the table, how would you propose or prefer to spend that? It would be very easy to assume that members of your communities, of your districts, and our constituents in Wyoming would give us a wish list of all of the new things, new services, new equipment, new technology, because, hey, it's all federal funds, let's start spending this money. But we heard something very different from the public, and that was to focus on sustaining and transforming basic care. And so pretty resounding feedback from our public was, and we have those ranked, you can see it in our application, we quantified those from the public input. It was really a couple of things. We want a financially viable small hospital. So our critical access hospital should be financially viable with an emergency department that functions and is available 24/7. So in the region, we should have access to OB, labor and delivery services. We should have a financially viable ambulance provider in the region that shows up quickly in an emergency when someone calls 911. We should have reasonable access to primary care somewhere in the area, either physically or through telehealth, and preferably integrated with some behavioral health care. And we want and should have access to the appropriate workforce for those basic critical services. So nurses, CNAs, physicians, EMTs, that's really, when you boil it down to its basics, what we heard from the public. And again, we kind of designed our initiatives around what we heard from the public. And that's why we had proposed such a large amount of our award. Instead of procuring new and shiny things, new and shiny equipment, consultants, various elements of technology, which we do have in our application, but somewhat separate. the bulk of what we had proposed is to shore up, sustain, and also transform our smallest rural hospitals and our EMS providers. So those two things, the Rural Health Transformation Perpetuity Fund and the amount of money we had proposed going to our hospitals and to our EMS providers, resulted in some negotiations that needed to take place with the federal government. And first and foremost, because of some esoteric federal regulations, it became clear that CMS may not and ultimately would not approve the perpetuity fund. And that's essentially where we stand today in our negotiations. Is it looks like that perpetuity fund has to be off the table. But where Governor Gordon's office and my department really spent the last 2 months negotiating was to not pivot on the amount of support, the amount of resources, and the amount of reform and transformation with those resources that would go directly on the ground to your providers, to your small rural hospitals, and to your EMS agencies, which we know, and this committee knows well. We've studied ad nauseum over the years, really are in some critical positions of being able to sustain the basic services, a 24/7 emergency department, access to OB or labor and delivery services, which you all know well. We've seen numerous closures over the past 5 to 10 years for OB services. We issued a huge study last summer on ground ambulance and EMS services in Wyoming, really showing the financial situation that our EMS services were in, with the basic conclusion that the multi-payer system and revenue from billing, private insurance, Medicare, Medicaid, et cetera, in most cases for EMS in rural Wyoming cannot sustain the cost of providing that care. So this is where we saw an opportunity for Rural Health Transformation Program to really step in and essentially help us address the fundamental economic issue with access to those basic hospital services and EMS services by helping to offset those high fixed costs in exchange for transformation and smart reforms in business models by focusing on those basics, partnering with larger hospitals to provide elective procedures that aren't critical or time sensitive in a higher volume, lower cost setting, to maximize revenue sources in the case of EMS by partnering with a critical access hospital, and by nature of that, you get a better reimbursement model from Medicare. A variety of things that you can see in our application that we really wanted to provide these financial resources in exchange for these smart and conservative reforms. And that's where we've been negotiating with CMS and the federal government for the past 2 months to ensure that instead of pivoting away to really short-term, one-time spending on only equipment or technology or out-of-state consultants, to really use these funds the best way we can to address those underlying economic issues in these service areas of high fixed cost and low patient volume. And so where we stand today, Madam Chairman and members of the committee, is we've submitted essentially our final alternative budget proposal to CMS. That occurred about a week and a half ago, or somewhere in that neighborhood, maybe a week ago. And CMS is currently reviewing that alternative budget proposal. Madam Chairman, I am optimistic. I certainly can't guarantee anything or speak for the federal government, but I am optimistic that we'll have a favorable deal on the table that is approvable by CMS, hopefully in the days to come. And again, those negotiations were intensive, a lot of detail, a lot of questions and answers back and forth from CMS to the department. I do have to thank Governor Gordon and his staff, our congressional delegation and their staff, and also CMS, Dr. Oz and his staff for engaging with us over the past 2 months in really trying to get this right. We wanted to take the legislative input from the previous session very seriously in what was legislated through House Bill 122 and try to execute the most favorable deal that we could for Wyoming. So in terms of next steps, members of the committee, we are awaiting a decision, hopefully an approval from CMS in the days to come. And then ultimately, in terms of implementation, what that would look like is, as we typically do with federal grants that become available during the interim period, we would work through the B11 process, which both the budget office, the governor's office, and the legislature would have visibility on, with exactly what that deal looks like. And then secondly, for the benefit of our providers, our stakeholders, and our public, we are doing the best we can to keep that website that I mentioned, at the Rural Health Transformation page on the Department of Health website, updated. Because of this protracted negotiation we've been in, we're probably about a month behind our originally planned schedule, but nothing that can't be successfully implemented should we get approval in the days or weeks to come from CMS. And so what we intend to do with the various elements and initiatives within our application is, once we have approval and the funding is released to the department, and essentially that B11 going through and being approved, we would start designing and issuing requests for applications across those initiatives and requests for proposals, depending on what the initiative is. We're anticipating that that will occur in between this month and through June. And similar to our application that I mentioned was designed kind of from the bottom up with our public, with our providers, with our stakeholders, we really intend to do the best we can to do the same with our requests for applications and requests for proposals. For example, with the Critical Access Hospital Incentive Program, we intend to use our hospital leadership, hospital CEO feedback to design the terms and the parameters and the various elements of that request for application. Same with our EMS incentive program, to do that with our association, with our EMS providers. And so we really want to keep that spirit of, instead of the department picking and choosing everything or picking winners and losers, to do that the best we can from the bottom up, knowing that we'll have a pretty aggressive timeline, and those applications and procurements will have to be relatively quick and relatively simple. Because in the year one of this award, we must obligate year one funds by the end of October and spend year one funds by the following October. And so that's essentially the timeline that we're on. We'll have about 7 or 8 months to do those obligations for year one, which essentially means having the procurements and the contracts ready to go. Doesn't necessarily mean all the money in year one has to be spent, because that extends to the following year in 2027. But Madam Chairman, I know that was, as my voice starts to expire here, that was a very high level 30,000 mile an hour overview of where we are with rural health transformation. I want to thank our legislature and our legislative leadership, especially over the past 2 months, for being engaged with us during these negotiations. And ultimately, I'm optimistic with where we are with the federal government, even potentially disappointingly having to sacrifice the perpetuity concept in this compromise, but maintaining the spirit of Wyoming's application to get this financial support and the reforms that are needed to our small rural hospitals, to our EMS providers, and ultimately leverage this opportunity to really do some great work for the state. With that, Madam Chairman, I'll certainly hand it over to our Deputy Director and Ms. McBride if they have anything to add, but happy to answer any questions that you all might have.
Thank you, Director. That was a fast and furious overview, but I really appreciate it. I appreciate what your team has done, what the governor's office has done in really looking at these and saying, what is it that Wyoming needs and how are we going to do this? And just really negotiating well for Wyoming and what we need with these rural and frontier types of areas in medicine that we do. I'm going to ask a question, and then I know that Senator Scott has a question. Mine is quick. Everything has to be allocated by, was there a certain time in October? I didn't quite get the date written down.
Madam Chairman, the obligation date for year one is, I believe, October 30th. My deputy can correct me if I'm wrong there. So that's when the funds for year one have to be obligated. And essentially that means having contracts or agreements in place within the various initiatives. The spending deadline for year one to actually have the money spent is 1 year from that date. So essentially into the fall of 2027.
All right. Perfect. Thank you very much. Senator Scott?
Madam Chairman. In support and elaboration for what the director said, last summer in mid-July, I had the opportunity to speak to Senator Barrasso, our senior United States Senator, and I said to him that all of a sudden we're hearing troubles, financial troubles, at our small rural hospitals on a scale we haven't seen before. And my diagnosis, what was wrong was that the federal government was not keeping up with its obligations to reimburse, and the costs were running faster than they were going up faster, and they were improving the reimbursements. And he said to me, "Don't worry, we just passed," and I gathered he was very much instrumental in working with Senator Murkowski from Alaska on this provision that got in that big bill. And he said that was designed and intended to solve that particular problem, to provide that support for the rural hospitals in particular. So I can see why the perpetuity fund was one step too creative for a big federal bureaucracy like CMS. But if they resist us on what the department has submitted, which is largely aimed at these rural hospitals and the services associated with them in the rural communities, it seems to me we're doing exactly what the Congress intended. And I guess my question is, has the department gotten that kind of support from our congressional delegation? And it looks to me like the bureaucracy is trying to defeat some of the intent of the Congress in this particular matter. I'm not quite sure how we approach dealing with that.
Madam Chairman, Senator Scott, it's a great question. I'll answer first very simply that yes, our congressional delegation, Senator Barrasso and his staff, Senator Lummis and her staff, and Congresswoman Hageman and her staff have been very engaged with me personally, the department, and the governor's office throughout this entire process. I think we would certainly agree with you, Senator Scott, that we have been trying to maintain not only the spirit within which our application was designed to address the issues that you mentioned, or attempt to address the issues that you mentioned, but also within the intent of Congress in the establishing legislation for the program. I think, and I won't speak for our delegation, but through our conversations, I think they would agree that that's essentially the spirit within which we made this proposal. Secondly, I would just add that as you mentioned, even if in this year, I'm going to have a hard time giving it up, but in this year, it does not look like the perpetuity fund would be allowable. But those other elements that you mentioned is quite frankly the reason that we've had these lengthy negotiations, is because we've been holding exactly to that principle, that not only the volume of the funds, but how the funds would be used and spent, and in exchange for the behaviors and reforms in those systems that we think are productive and practical, in order to get you make best use of these funds to get that behavior change that I know this committee has discussed over many years, and quite frankly, that we discussed with our hospital CEOs directly over the development of this application. It's hard to get consensus on exactly the best way to spend an amount, a volume of dollars like this. But I'm pleased with the engagement, the partnership we've had with our hospital providers, our EMS providers, and others to try to leverage these funds in the way that you're mentioning, Senator Scott, and that is at its most simplified level. We know that even the basic services that our public told us they need and want, emergency department, OB services, stabilizing services with trauma and stroke and the imaging that's necessary to do that. Those are very expensive just to have available in rural communities, just to have the readiness, similar to ambulance services, which you all know, one ambulance in a rural community costs on average $500,000 per year. And our small ambulance agencies, even if they build 100% accurately, correctly, all of their commercial billing, Medicare billing, Medicaid billing, would be able to recoup just a fraction of that. So that necessitates our smallest agencies relying on volunteer labor, county budgets, bake sales, golf tournaments, all of the things that you've seen your EMS agencies do, and helping to offset those fixed costs to essentially through reform and practical transformation, but also through these finances to offset those fixed costs, is essentially where we proposed half of this award. In fact, just a little bit more than half of this award going to and trying to accomplish. So long-winded answer to your question, Senator Scott. I think even with this compromise, should CMS approve it, I think we would be able to begin and catalyze the types of investments and reforms that I heard in the spirit of your question. And I'm optimistic that our friends at CMS will ultimately say yes and approve this compromise proposal.
Representative Costin.
Thank you, Madam Chair. Thank you, Director, for fighting for the perpetuity funds. I think it was the best approach. I really appreciate the work of your department and the governor's office. Also, thank you for not fully expiring on us this morning. So appreciate it. Can you tell us, it's my impression we have received some funds already. What would that look like? And then can you just a few more details on the alternate application that you had to put in?
Madam Chairman, Representative Clouston, so your first question, no, we have not received any funds from this, from Rural Health Transformation yet. That requires essentially full budget approval first from CMS, which again, they have our submission on the last or alternative budget proposal, and we're awaiting their decision currently. So just to be clear, for the legislature, for the public listening in, for our providers, the Department of Health is not sitting on any funds from this program that have been released. If we had funds in our coffers, you would know about it, and we would be engaging in those communications to make sure that our folks were aware of how to apply for them or get them. So that has not occurred yet. Your second question on the alternative proposal, it's essentially exactly what our original and approved application looked like, with the exception of two items. We have removed the Rural Health Transformation perpetuity in this alternative proposal or budget proposal. And because in your legislation, House Bill 122, the legislature did not authorize our catastrophic major medical plan that we had in our proposed initiatives, that we have taken that out. That was a very small component, very little amount of money, but those two elements have come out. And I do want to be, or at least put a plug in, because I've had discussions with many of you, as well as our appropriations chairs, and this will sound a little bit selfish from your Department of Health Director, but I do very much believe in the concept of the Rural Health Transformation Perpetuity Fund that we worked with the legislature in designing. And while that might not be approvable at the federal level this year, I do think the concept warrants further, attention, whether that's something that over the coming years we at least look at or research, study on developing something similar in the state. It's just a very unique and Wyoming specific financing vehicle that I think could be very productive and fruitful for the state when it comes to the economic model of how we could possibly sustain these basic services in our rural communities. And so I certainly want to keep that both with this committee and our appropriations committee on the table should federal preferences or interpretations change going forward, but also just as a concept for the state to continue to consider with how we finance or how should we finance our critical access hospitals and our EMS providers and our workforce that we've been so desperately trying to develop. I think the concept and the elements that were in that perpetuity and designed into the legislation this past session are just extremely innovative and exciting. That during the interim periods, during the 5-year grant award from Rural Health Transformation, that we could look at customizing various elements just on the state side without federal strings for something similar. But that's not something that requires immediate attention, just something I'd like to keep on the radar for this committee and our legislature.
Thank you, Mr. Director. Any other? Okay. Co-Chairman Ottman.
And Madam Chairman, it did look like Senator Hutchings has had her hand up for a long time.
Oh, we'll go to Chairman Ottman and then Senator Hutchings. My apologies.
Thank you, Madam Co-Chairman. Either director or deputy director, I just have a question. Recently, in one of the SLIB board meetings, we saw, or it was that how to rate things and the importance and whether, because I know there's a lot of counties and different ones looking and saying, oh, we got to get this whole amount. I noticed that over the course of that meeting, that things were changed up and looked at. And I was wondering how it's going to go with this. Are we going to look at, or should the applications from the counties, so they have some direction, look for things that actually could be completed at that time, or first steps, or what would be some guidance for how they apply? Because it's only 5 months. Thank you.
Madam Chairman, I'll defer that. It might be better in person. Franz, do you want to tackle that question?
Madam Chairman, I'm Co-Chair Ottman. My name is Franz Fuchs, Deputy Director, Department of Health. So we envision kind of two things. One is going to be as rigorous as we can within the time allotted, a public engagement process in actually developing those requests for applications and the rubrics that we'll score them with. And so we do want input within the constraints of what is approved, of how, a hospital or an EMS agency would demonstrate that it's meeting the deliverables that we're requiring. The second thing is the rubric itself. We do want to standardize them to the extent we can. And so we want to have the scoring be very transparent. We want to try to eliminate as much subjectivity from that scoring as possible. So I do think the combination of trying to get that engagement and developing the rubric and then having that standardized rubric will hopefully give people a clear idea of how they should apply. We definitely do not want a bunch of free form text applications. We want, basically people filling out forms and providing quantitative information and responding to very specific questions when they apply. So that's how we intend to proceed with that.
Okay. Senator Hutchings.
Thank you. I know I'm up here in the corner and I appreciate the director for noticing my hand up. A lot of my questions got answered, but my favorite question to you is, once we get this money, what do we have to do for the federal government? That's number one. And I really like the perpetuity fund, and like the way you guys kind of want to still kind of work with that. But one of the things I'm thinking about, especially with EMS and the cost of EMS, cost of critical care, you were asked to do something that would be sustainable. How can we, even with billions and billions and billions of dollars, sustain the care that the basic care that people want? So number one, what do we have to do for the federal government? And number two, is this really going to be sustainable?
Madam Chairman, Senator Hutchings, two excellent questions. I'll take them one by one. Number one, we have to do a lot with the federal government in terms of reporting, compliance, subrecipient monitoring, just like any federal grant. If you go back to ARPA, CARES, federal grants that the Department of Health has through our, public health division, behavioral health division, you name it. We're actually pretty good at grant compliance in the Department of Health, so I'm less worried about that. But it involves a lot of bureaucratic reporting, budgeting, things that are just part of that normal process for anybody that receives federal funds through the Department of Health. They're considered a subrecipient, so we have to have documentation of that. And like I said, through many federal grants, we're pretty well established in managing those types of things. But on the other side of that coin, we have tried to design the biggest parts of this program to be as simple as possible. So if you look through our application, and certainly when it becomes public, this alternative, if it's approved, this alternative proposal, you'll see things that are much more simple than you might otherwise see. So for our hospitals and EMS providers, really making those payments based on the completion of those deliverables, which are very simple. Do you provide OB services or labor and delivery services? And in some cases, have you brought those or have agreed to bring those back online? Then we would make that incentive payment. So in that sense, we're trying to simplify, take the bureaucrat out of the bureaucracy, so to speak, and say, let's make this as simple as possible. But Senator Hutchings, make no mistake, there's a lot of grant compliance and reporting that comes with federal grants of this size, and that will be the case with this program. Secondly, to your question on sustainability, that's the biggest issue of why we've been negotiating so hard with the federal government, is because it is very easy in grant programs like this to, when pressed by either the federal government or you all in the legislature, when you're asking, how is this going to be sustainable? And the answer is, well, we've asked our recipients to come up with a sustainability plan. That doesn't meet the standard that I would like or that we would like to have in an investment like this. But it has been challenging because essentially our original sustainability plan was largely that perpetuity fund, which looks like it may not be allowable. And that perpetuity fund allowed us to spend less in the short term. And those investments through the Treasurer's office would generate essentially additional revenue for the state to then stretch that out over a long period, 20, 30, 40-year timeline. That would be the sustainability we were looking for. With that potentially not being allowable, Senator Hutchings, I'll be very blunt in that there's certainly concern over sustainability of these programs. However, I'm confident in our ability with the governor's office and with our providers, especially our hospitals and our EMS providers, that with how we have designed, even without the perpetuity fund, these initiatives, that those investments can absolutely pay dividends beyond the 5-year period. So if you think of the ability to offset for even a 5-year period of time, that type of high fixed cost for OB, for emergency department, for EMS services, that revenue situation and that balance sheet picture for those small rural providers should be greatly improved over this 5-year period, that I'm hopeful that they could commit to longer term adherence to this type of program. But I do want to be clear, Senator Hutchings, that I don't want you to hear the Department of Health or the director say this is 100% sustainable, because there needs to be engagement over this 5-year period with our Labor Health Committee, with our Appropriations Committee, on what does 2032 and 2033, when this program expires, what does that look like? I testified in front of the Appropriations Committee a couple of weeks ago on a similar question, that you certainly have commitment from me that should I still be here, that the Department of Health would not come in to say, hey, the general fund needs to fully replace the Rural Health Transformation Program in 5 years. That is not happening. And even within these hospital and EMS and workforce initiatives, I think what we would be looking at financially is what fraction of that, based on the behavior of those systems, the transformations we were able to achieve hypothetically in this 5-year period, what is worth sustaining beyond the 5-year period. That certainly will not be $100 million per year. But I do think, like I mentioned before, with this committee and the legislature continuing to consider what would a state version of that perpetuity look like at a much smaller amount for much more targeted or specific types of services or financing, could be warranted over this 5-year period. And given the work that you all did this past legislative session, some really creative bills and budgeting, I'm pretty optimistic that in partnership we could develop the core elements of this application into a state sustainable initiative going forward. But it is absolutely a challenge.
Director Johansson, I love your answers. Thank you so much. I appreciate you. And get better.
Thank you, Senator Hutchings.
All right. Deputy Director.
Madam Chairman, we do have, Senator Hutchings mentioned some federal strings, and I thought that might be a good segue to the latter half of the slide where we talk about the state policy actions, but I'm happy to wait if there's other questions regarding the director's testimony before we pivot to that.
I think we have a couple
Madam Chair.
more questions on these things, and we will go to Senator Crum first.
Thank you, Madam Chairman. My question would be, what does the director and department need from this committee to help them to ensure that we receive the money that we applied for?
Madam Chairman, Senator Crum, thank you for that question. That will be a perfect segue into what our deputy will give an overview on. I'll just cue it up here. There were various elements of the federal guidance that were called state policy action items that states could elect to include in their application, which we did as well. A couple of them that are already in motion or will be in motion once we implement. There was an incentive in the federal guidance for states that would submit or implement SNAP waivers. You guys have had that discussion for multiple sessions. We engaged with Director Schmidt and the Department of Family Services on including that in our rural health transformation application, which came with higher scoring and potentially additional funding from the award. And that basically has already happened through executive order. And Wyoming's SNAP waiver, as I understand it, again, this is not my agency, was fully signed between the state of Wyoming and the federal government. So that was an example of a state policy action that was included in the rural health transformation guidance. Senator Crum, there's a few others that we queued up for this committee in terms of need, potentially in your subsequent meetings later this interim period. And that's really around scope of practice and licensure. So there's a few areas within the rural health transformation federal guidance that we brought to the legislature as interim topics when and those examples I'll have our deputy director go through, but they include, scope of practice for dental hygienists, interstate compact for physician's assistants, and I believe scope of practice around pharmacy services. But we have that included on the slide, and we're leaving that up to the legislature. That obviously would require a look at the statutes and the practice acts for those various areas, but potentially something you could discuss or consider in terms of legislation at your subsequent meetings. But Senator Crum, if it's okay, I'll hand it over to our deputy director to go through those in a little bit more detail.
Thank you.
Senator Scott.
And I have, there we go. Thank you. The question I have, part of this originated back last summer. We were seeing a number of our hospitals get in financial trouble on a scale that we had not seen before. With the way CMS has stalled the implementation here, and with the uncertainties that do remain about what they're going to approve and what they aren't, if this continues to go on, my basic question is going to be, what are the risks we're going to have a crisis or two in our hospital community that requires more immediate action? And subordinate question to that is, are some of these critical access hospitals and providers privately owned? Because if we get into a legal argument with CMS and their role as the regulator of what prices these hospitals can charge, we have some special advantages to having a private one as a plaintiff if we do have to go to litigation. So my basic question is, are we going to get action fast enough out of the feds? And is it likely to solve the problem, or we still got a real risk of losing some hospitals?
Madam Chairman, Senator Scott, as I mentioned, I am optimistic that this process won't be dragged out too much further. And we hopefully will see federal approval for our alternative proposal in the days or weeks to come. Leading to your subsequent question on this financial status of our small and rural hospitals, I'm just from my perspective less concerned about imminent risk of closure for these providers. Those folks or the hospital association could certainly countermand me if they disagree. I don't think that's in the short-term picture. But I think it's worth mentioning, Senator Scott, because we talked about this before the session and during the session with members of the committee, with you in particular. I do think that some of the action the legislature took in the previous session was very positive and also ties in directly to the concepts or initiatives we had in this rural health transformation application. For example, the legislature approved something that this committee, the Labor Health Committee, had discussed for the past 2 or 3 years when it comes to labor and delivery and OB services. Now, keep in mind, this is only on the Medicaid rates and book of business, so it's certainly not a panacea. But the legislature did approve for us to move to 101% cost reimbursement for all inpatient services at critical access hospitals for those that provide OB or labor and delivery services. So that's on the Medicaid side. It's not an insignificant amount of funding, and it ties again directly to our initiative on sustaining and bringing back OB services that's in our rural health transformation application, but this is outside of that. So the legislature has invested in that, and that will take effect on July 1st of this year. Again, I think it can be very helpful to the book of business for many of our hospitals and potentially be an incentive to bring back some of those services that have been shuttered over the years. Secondly, the legislature passed a bill. I can't remember the bill number. If memory serves, it was Senate File 4, but don't quote me on that. And that was for EMS rates in Medicaid, a significant investment. You guys passed that with an overwhelming majority to increase Medicaid reimbursement for EMS services with a carve out for rural and super rural providers. So again, that takes effect July 1st. We'll be looking at cost plus reimbursement on the Medicaid side for EMS rates, and that's very positive. So Senator Scott, to answer your question broadly, I think we have some items in place that hopefully mitigate or prevent circumstances where we would see imminent risk of closure in the short term here, but something that's absolutely front of mind and why we've engaged so heavily with our hospital association and our hospital CEOs to not only make sure that we got the application right, but in this negotiation and compromise proposal that they were supportive of whatever deal we end up striking. But I'll certainly hand it over to Deputy Director Fuchs if he has anything to add there.
No? Yes?
Madam Chairman, I don't have anything to add to the director.
Okay. Let's go on to the second part of this slide.
Thank you, Madam Chairman, Madam Co-Chair. On the second half, you'll see a bullet called pending state policy actions. And as the director mentioned, these are specific items that remain outstanding as far as commitments that we said we would bring to the legislature for consideration. And what these do, these are not make or break. They don't affect all of the funding. They affect plus or minus a few percent of the funding of our scoring. So if we do not do these things, then we will lose some money, but it's not, as far as the big scheme of things, significant. So we brought these for your consideration. We have no opinion as far as whether or not they would be positive or negative. We really think, there's plenty of people in this audience and in the public that would be able to speak to this, and they are, some of them are probably more contentious than others. But just starting from the top, Wyoming is a state that has not signed the physician assistant licensure compact. So that's one policy action that we could take as a state that would essentially streamline some of the licensure requirements for PAs coming in from out of state. We've done that with nurses. We've done that with EMTs to some degree. So again, this would be one consideration for your to look at. But again, nothing here is purely positive or purely negative. These are policy considerations that have to be weighed on their merits.
Senator Scott.
It's not clear to me which document Francis is referring to.
Madam Chairman, Senator Scott, I can present the slide, but it's our second slide on our rural health transformation brief. It'd be helpful to share this.
Yeah, so it's the slide that says agenda. We went through kind of the rural health transformation application and where we're at. And then down the second arrow is pending state policy actions.
So that slide there. The second item is pharmacist scope of practice, and I'm gonna have to refer to our application here to kind of get to the details. So I apologize, but just give me a second. So currently, pharmacists in Wyoming can only prescribe and administer vaccines, epinephrine, and opioid antagonists. And this requirement would expand that scope of practice. The policy score rewards states that allow prescribing without reliance on statewide protocols or formularies or administering any drug by class. So essentially be expanding the type of drugs that pharmacists could prescribe beyond those limited categories that we have currently. Additionally, the policy score would reward states that allow pharmacists to be able to order and perform any lab test based on clinical judgment.
Okay. Sorry, we're going to stop you there. I think co-chairman has a question.
Madam Co-Chair and Director Fuchs, is this in writing somewhere where we're going to look at and see what that licensure is? Do we have it in here, or can you repeat that again?
Madam Chairman, Madam Co-Chair, I'm happy to repeat it. We're happy to work with LSO too. If you are interested in exploring these concepts, we can certainly work with any subcommittee you'd like to try to draft what we don't have required or legislative changes that we've proposed yet. All we have is what's in our application, the concept of what these would be. So just to repeat that, currently pharmacists can only prescribe a certain limited number of classes of drugs, and those include vaccines, epinephrine, and opioid antagonists. And so this policy action would expand that to basically allow prescribing without reliance on statewide protocols or formularies and administering any drug by class. So it does sort of expand that scope of significantly beyond those three limited categories. And it would reward states that allow pharmacists to be able to order and perform lab tests based on clinical judgment. So again, I want to emphasize, we have no position on this. This is really a discussion with your pharmacist community, with your provider community, as far as the left and right limits of that scope of practice. And we certainly don't want to put our finger on the scales as to, whether this is a good idea or not. All we're saying is that we will get a slightly higher amount of money if we follow through with this policies action. Madam Chairman, the next thing is, I believe, the dental hygienist's scope of practice. And so currently, Wyoming excludes 6 procedures that we'd have to allow. So these are the things that would have to be allowed by dental hygienists. The first thing is diagnosis of oral conditions. Second thing is prescriptive authority. Third thing is supervision of dental assistance. 4 is direct Medicaid reimbursement. 5 is dental hygiene treatment planning, and 6 is provision of sealants. So as you can see, this would be a pretty big departure from current practice, which we limit to 2 things. They currently allow 2 of those 2 task categories of the 8 that the feds require. And so the feds are incentivizing providing those additional 6, or allowing dental hygienists to do those additional 6 tasks.
Committee, any questions on the dental hygienist?
And then, Madam Chairman, the final is the nutrition continuing medical education for providers. This may not necessarily need to be legislation. This could be potentially the Board of Medicine adding it to its rules. And so we can certainly, if the legislature or this committee is interested in pursuing that, we could certainly discuss with them, what the best way to proceed is. But that's the last outstanding state policy action that is incentivized. And this would essentially require that doctors essentially be trained on a periodic basis on nutrition. And
Okay,
so, Madam Chairman, that's the state policy actions which this committee could certainly pursue if you're interested in. But again, we recognize these are potentially controversial, and we certainly have no recommendation as far as whether you should or not implement them.
perfect. Thank you very much, Director. We have a couple of hands. Representative Wasserberger.
Thank you, Madam Chair. I was just curious on the expansion of some of the medicine and practices that we'd give with our pharmacies. If the federal government was to open us up to some extra appropriations, would we be expected to spend that right away, or what's the flexibility with that if we were to go that route? Thank you.
Madam Chairman, Representative Wasserberger, so the policy actions are decoupled from the total funding. They essentially give us more money if we do these things, but we are not required to spend any of the money on them. So it's really just these are legislative changes that we are encouraged to implement. But at the end of the day, the money would still be directed at the existing application areas. It would not necessarily flow to dental hygienists, for example.
Representative Rodriguez-Williams.
Thank you, Madam Chairman. Deputy Director, so I assume we're going to hear public comment from some of the involved parties or organizations, associations, et cetera, that are involved in some of these policy actions. Has the department also done their homework and met with some of the involved parties, organizations, community colleges that also provide some of the education behind these practices?
Madam Chairman, Representative Rodriguez-Williams, we have not done a lot of that. We have done the research as far as what the requirement is, and we are hoping to drop that into your lap. But we have been spending most of our time, unfortunately, fighting with the federal government on the application itself for the past few months.
Anybody? Is there another hand up online? No. Okay. Any further questions on this side? Okay. We do have some stakeholders, and obviously there will be, I'm sure, people from the public that want to testify on this, but we are going to take a like a 7-minute stretch break right now. back. If everyone would find your way back to your seats. All right. I hope everybody enjoyed that legislative 7-minute break, which was like 12-minute break. Okay, we're going to call this meeting back to order. And up next under rural health transformation, we have some stakeholders, and I believe that we have in the room first. In the committee, you should have some, and there's some handouts for the public. Is Inseparable or EOS here? Okay, if you guys want to come, and then after that, we will have other stakeholders and public comment. All right, welcome. If you will state your name for the record and give us your little
All
presentation.
right. Good morning, Madam Chairman. I'm Caitlin Castaneda, and I'm with the firm of Bronstein Hyatt Farber Schreck in Cheyenne. And with me this morning, I have Marianne Gibson from Inseparable Action to present some ideas around the rural health transformation and possible partnerships in the state of Wyoming.
Thank you, Caitlin. Good morning, Chair Brennan and members of the committee. My name is Marianne Gibson, and I'm the Vice President of Youth, Workforce, and Crisis Services with Inseparable. And in front of you, you have a slide deck, and my talking points will be aligned with those slides. I'm so grateful for the opportunity to be here today to share some information about how Wyoming can strengthen its behavioral health response system. So to begin, I'll share a little bit about Inseparable. We are a national mental health advocacy organization that was founded in 2020 on the principle that mental health is inseparable from physical health. And our goal is to drive transformative change at both the federal and the state levels by engaging bipartisan policymakers, mobilizing support, and advancing mental health and substance use disorder policies to help all people thrive. So our organization is built to deliver mental health policy reform that saves lives and improves the well-being for all Americans. And to do that, we focus on 4 main pillars. The first is improving youth mental health by ensuring that children have the resources and supports that they need to thrive. The next is building a crisis response system focused on recovery so that anyone having a mental health emergency has someone to talk to, someone to respond, and a safe place to go. Next, we want to ensure that all people have reliable and affordable access to care so that people don't have to choose between seeking mental health care or financial instability. And then lastly, the underpinning of it all is really strengthening the behavioral health workforce so that we can ensure that help is available when and where it's needed. So I want to share a little bit more about how Inseparable approaches our work. Being a national organization, we partner closely with states. We know that strengthening mental health takes an all-hands-on-deck response, and we're really happy to work with so many committed partners at both the national and the local levels. And when we work with states, and currently we're in about 20 states and looking to grow in the next year, we work with people that are on the ground because we know that they know what's best for their communities. And our aim is to really use the tools and resources that we have available and have access to amplify the needs on the ground and support forward progress by advancing strong mental health policy together. So just wanted to highlight some recent success that we've had. Even though we are a relatively young organization, we're really thrilled with the progress that we've made so far in states. We've recently celebrated having 100 state policy wins, which was a really exciting milestone for us. And some examples of what those wins look like include expanding and supporting legislation that expands the behavioral health workforce through enacting licensure compacts, strengthening insurance coverage for people with mental health conditions, supporting investments in 988 and the crisis continuum. I also want to highlight a couple of resources that we have available for you all as decision makers. One primary area of focus for us is publishing resources, including reports and model legislation that can be helpful for decision makers. Most recently, we released a workforce report, which includes a comprehensive overview of mental health workforce needs and provides a snapshot of where each state is. The report reviews a number of different topics and illustrates specific data points for each state to meet the needs of their constituents, including looking at how states can reimburse for mental health services compared to physical health, how often constituents need to go out of network for care, and the status of the adoption of various behavioral health compacts. And overall, I just want to really acknowledge and recognize the work that Wyoming has done, especially around investing in the behavioral health workforce. The state has enacted collaborative care and has joined the SIPAC and the Counselors Compact, which has expanded access to providers in state. But what we've learned nationally is that the workforce shortage is not just a pipeline issue, but also a payment and coverage issue. And the report does point to some actionable steps that can be taken to expand the workforce without training new providers. So encourage you all to take a look at that. So now I want to pivot to talk more about some opportunities for Wyoming with the Rural Health Transformation Program that we just heard an excellent overview of. When awarded, Wyoming will receive considerable funding under this program, which provides a tremendous opportunity for the state to strengthen its healthcare delivery system. And we have had the opportunity to review the application, and through our work at the national level, we know that many rural states experience similar challenges. So we wanted to highlight some opportunities that we see that could further strengthen Wyoming's behavioral health continuum. And to do this, we've organized our recommendations into 3 main policy buckets. The first is around strengthening the 988 crisis call center. The next is expanding and strengthening the crisis continuum, and then also looking to further invest in the behavioral health workforce. So beginning with the 988 system, one area of opportunity that we see is around strengthening and sustaining the 988 crisis response system. We know that the 988 suicide hotline has become a core public health and public safety resource for the state. In 2023, the legislature took a very important step towards sustainability by authorizing the 988 Trust Fund. And even though there is limited funding to this resource, the system is performing very well and demonstrating value already to constituents. In 2024, there were over 7,500 calls that were answered by Wyoming's 988 Crisis Call Center. Call volume increased by 30% between 2022 and 2023, meaning that there is more awareness of this as a resource. The in-state answer rate increased from 0% to 90%, which is a very important metric because it shows that people that are calling 988 are being resourced by people that are in the state of Wyoming, and they are more familiar with the resources available to those folks. And we are seeing emerging evidence around the impact of 988. Recent data has shown that where there is more 988 coverage, suicides are actually declining. Another benefit of this resource is we know that fewer than 2% of people that call into 988, it results in the involvement of emergency services. And so most callers can be stabilized without intervention from EMS or law enforcement, which we know reduces the system strain and public costs. And so an opportunity that we see for Wyoming is taking some of the funding available through the Rural Health Transformation Program and investing that into the 988 call center. We think that an amount could be roughly $20 to $30 million over the course of the grant. And this would help ensure stable 24/7 in-state operations which would protect the system from an annual budget volatility. Additionally, another way to grow the 988 system could be investing in a warm line to handle lower acuity, high volume calls, which would further reduce the pressure on 988. We had heard that there are many people that call into 988 very regularly. They're high utilizers, and they don't necessarily have a behavioral health emergency, but they're just looking to connect with someone. So a warm line could support those folks without straining the 988 system directly. Another option for leveraging 988 funding through the Rural Health Transformation Fund would be looking at ways to support alternative transportation for mental health emergencies. So Oklahoma has implemented a program called Ride Care, which is an alternative non-law enforcement transportation option for folks that need longer care or that they need longer transportation to recovery centers or crisis care. And this would free up law enforcement to be able to respond to other sorts of calls. So all in all, we think that a stable, well-coordinated 988 system aligns with Wyoming's values of efficiency, local responsiveness, and prevention, and would address crises earlier, ultimately reducing the reliance on higher cost emergency services and alleviating pressures in emergency departments. Now moving on to opportunities around strengthening crisis coordination. We know that there's been some really innovative work happening in Wyoming in partnership with the Sheriff's Office and telehealth mental health providers to provide services to folks in mental health crisis who interface with law enforcement. So there's currently a 5-county pilot program with the Sheriff's Office that's being supported by a $2.5 million grant from the Sheriffs and Chiefs Association that was begun last fall in 2025. And the goal of this program is to have law enforcement officers connect people in crisis to mental health services virtually. So we think there's an opportunity to really look at how this program is rolling out and to assess its impact and evaluate it for its outcomes. And if it's meeting its stated goals, look at ways to further strengthen and sustain this sort of program and also scale it statewide if appropriate. And then lastly, I want to pivot to talking about opportunities around the workforce. So every county, as you all are well aware, in Wyoming is designated as a mental health professional shortage area, making workforce strategies essential to long-term system stability. The state can expand access by thoughtfully building the state's mental health provider pipeline, including ensuring that professionals that are trained in Wyoming remain in the state. So we heard a little bit about provider compacts earlier, but I just wanted to highlight a couple of others that the state can consider. The state is currently participating in both the Counseling Compact and the SIPACT, but additional behavioral health compacts include the School Psychologist Compact and then also the Social Work Compact. And we see this as a relatively low-cost opportunity to expand workforce capacity. Our estimates show that to implement a compact, it's approximately between $10,000 and $30,000 to then look at rulemaking, minor IT or licensing reforms, and initial staff training for the implementation setup. So ultimately, compacts can preserve the state oversight of these professionals while also expanding the pool of clinicians available to serve folks in Wyoming. Another opportunity that we wanted to highlight is supporting mental health care in primary care settings. And we know that there's been a lot of really excellent work happening around this, including integrated care and adopting the collaborative care model. But given that Wyoming in primary care physicians are already managing a substantial amount of behavioral health needs, often without access to specialists, through training, you can really bolster the way that existing providers can support people with behavioral health needs with your existing workforce. So there are a couple of trainings that we've seen implemented that have been effective, including out of the REACH Institute, there's a program called the Patient-Centered Mental Health in Primary Care Training Program, which equips clinicians with information on how to better treat folks who may be presenting with behavioral health needs. Montana is currently implementing this program and has trained over 82 providers using this model. This is a program that Virginia is also implementing currently through their mental health access program. And this is another training program that is relatively low cost overall. It's about $2,000 per participant. So it's a way that through investment, you could really grow the skills of the current workforce and train them better in how to respond to behavioral health needs. And then lastly, one opportunity that we wanted to bring attention to is ensuring that students that are trained in Wyoming have viable paths to employment in the behavioral health field. We know that there was previously a work group that was led out of the governor's office that was focused on disentangling and streamlining the state's behavioral health provider network and their the various licensures. And so we know that there's over a dozen behavioral health licensures in the state, many of which are not currently reimbursed. And so we think that there's an opportunity to bring back that working group to really make sure, in partnership with community colleges and insurers, to ensure that there are credentials that then match future employment opportunities, and that those opportunities are also reimbursable, which is really the key to sustainability overall. So yeah, with that, I will pause there. Happy to answer any questions, but these are just some options for you all to consider as you think through additional opportunities for the rural health transformation. Thank you so much.
Thank you very much. In committee, I will just, hopefully you've noticed, there's a lot of things in our agenda that kind of go under, like they kind of go under two different spots. And so there might be some things that kind of look like, well, they could kind of fit under either rural health transformation or maybe into one of our more specific topics. So committee, any questions? Senator Hutchings.
Thank you, Madam Chair. Question for the young lady. I'm hearing a lot of, let's spend some of this good money on mental health, behavioral health, creating jobs, licensure, but I didn't hear any options about faith-based. There are plenty of people in our churches today that have clinical degrees in psychology and helping out people that are going through issues. Is there a reason why you haven't mentioned that, or is it just something that never came to mind, and that's using faith to help with behavioral health? Thank you.
Thank you, Senator Hutchins, for that question. No, there's not a specific reason why it wasn't mentioned. And we think absolutely that faith-based organizations and churches play a critical part in supporting communities and can serve a critical role in supporting people with behavioral health needs. So, yeah.
Representative Rodriguez-Williams.
Thank you, Madam Chairman. Ms. Gibson, a couple questions for you. Does your organization collaborate with other, there's a lot of topics in here, suicide prevention, behavioral health. Do you collaborate with other organizations that have statewide goals for Wyoming? I guess I just have a concern about overlap. And then my other question is specific in regards to one of the recommendations for the 98 Suicide Prevention Lifeline. You talked about one of our grants that WASCOP has for virtual care with law enforcement, the pilot program. And I'm just curious if you talked about evaluation, is there not already some sort of mechanism when they were awarded the grant to evaluate outcomes already in that, or that you're aware of?
Sure. Thank you for the questions. I'll take the first question first. We absolutely love to partner with other organizations that are doing work. And we've had the opportunity to connect with the Behavioral Health Advisory Council in Wyoming. We've connected with NAMI of Wyoming and are always looking to make additional partnerships. So the short answer is yes to that. The specifics of the outcome measures for the WASCOP program, I'm not familiar with. Like, presumably there are various metrics that they should be abiding by. We just wanted to highlight that as a good opportunity to connect people in behavioral health crisis who are interfacing with law enforcement to services directly. But yeah.
Representative Clouston.
Thank you, Madam Chair, and thank you for being with us this morning. This committee has done a lot of work on prior authorization and credentialing for traditional healthcare, and mental health is healthcare. Can you speak at all on how those subjects maybe affect mental health care in Wyoming and nationally?
Yes, and my colleagues that work more on the coverage side would be better positioned to talk about prior authorization more specifically, but broadly, we know that prior authorization is a barrier to mental health care. And so eliminating prior authorization as much as possible expands access, and we are in support of that.
Committee, any further questions? Great, thank you very much.
Thank you.
Thank you, Madam Chairman and committee. And then up next, I have Dr. Brent Myers from ESO, and he's going to present some of the same concepts for their company. And we have some slides if you don't mind if I pull those up. Okay.
Thank you.
Madam Chairman and Co-Chair, thanks so much for having me. While we're pulling those up, I'll do just some really quick introductory remarks. My name is Brent Myers. I'm the Chief Medical Officer of ESO. I've started working at a rural hospital in North Carolina as a orderly in the emergency department in 1986, and I've been an EMT since 1990, and I'm an emergency and EMS physician. And what we want to just briefly talk about today is how the concepts of emergency departments and EMS that have historically been thought about somewhat distinctly. Now there's a through line all the way between the first call to the 911 center to the ultimate outcome of the patient. And so that's what we want to talk about. And then in the rural health transformation, there's a way we believe that the technology that we bring forward can allow each of those local communities to maximize the input and the outcome that can come from this once kind of a generation.
Excuse me, Madam Chair.
Oh, yep, just
better now.
There you go.
Senator.
He was fading out. So,
That was probably my microphone. Is that better now?
Oh,
yeah, a
Yeah,
lot better.
and-
Thank you.
Sorry about that. So as we were saying, we'll start talking just very briefly about what ESO is, and then we'll get right into the data that I think isn't so important. So ESO is a technology and data company that was founded 23 years ago. And the director of the company, that's the founding CEO, was in charge of performance improvement for Austin Travis EMS in Texas. And he went to improve EMS, and all of the data were on paper. And he could do no performance improvement because he had no data. And so he found a contractor to start writing code, and they founded the company 23 years ago with the express purpose of improving outcomes through the power of data. Fast forward 23 years, we are now the largest integrated data set from 911 to hospital discharge in the world, 23 million cases that flow through our software that allow us to predict with high reliability what's going to happen to patients when they call that emergency number. And what we've been working on over the past year is the ability to take those data and no longer look at it only as an episode, which 911 normally does, and turn that and look at it from a patient-centered view, to monitor that patient over time, as opposed to just, there were 37 911 calls last year. How many patients were involved and what happened with them, and we'll get into that. So the first thing I'd like to talk about is how we ended up where we are today in EMS. And I'm not going to go through the entire history of EMS, but just very briefly, we were founded in the late 1960s in the United States due to traffic accidents on the interstate highway system. And the system was designed to respond to that one problem. And if you think about that problem, and then you think about a heart attack or a stroke or a shooting or a stabbing, they all flow into that same concept, which basically means you call the emergency number, EMS comes, you go to the hospital, we take care of you. That makes sense for those patients. Today, however, across the United States, only 8% of the people that call 911 are in one of those categories. Most of the patients that call 911 are calling for an unscheduled medical need, not for an emergency medical need. And so we're still taking that same system that was designed in the late 1960s and putting all of these patients into this pathway that takes them to the emergency department. And what we now feel confident that we can describe is there is a way for 10, 30, 40% of those patients that call 911 to be appropriately treated in some other avenue of care. We no longer have to take every patient that calls to the emergency department. And if we think about the rural health opportunity, the ability to sustain those hospitals while not overcrowding them, to keep those ambulances available in those rural communities for true emergencies, I think there's something to really be said here. So we'll talk first about the way that we can do that from dispatch. The way that the calls are interrogated in the United States, there's multiple different softwares, but they all come to the same basic conclusion. Patients have an acuity score. We've been able to attach that acuity score all the way to their hospital outcome. And as a consequence, we can come back and say, if you call with this type of complaint, your chance of having a time-critical emergency is less than 1%. Then we can start thinking about nurse advice, or we can start thinking about an alternative transport to a clinic, or that type of thing. We also have looked at this, as I said, from a patient-centered perspective. So if we think about who calls 911 every year, 80% of the people that call 911 only call once a year. Said the other way, 20% of the patients that call 911 call multiple times a year. But if we think about that from the episode perspective, those 80% of patients are only responsible for 55% of the volume of EMS traffic. In other words, 20% of the patients create 45% of the EMS volume. And the top 3% of those patients create 16% of the EMS volume. And so what we are looking to do is to be able to appropriately provide care for those patients that may not involve sending an ambulance and responding all of the time. And we think there's a very safe way to do that. So if you're following along on the slides, if you'll follow with me to slide number 15, it's called Activity 1 Transfers. And this gives this concept operationalized. So we've heard already that there are rural hospitals that have difficulties, both from a financial perspective and from a resourcing perspective. We've heard that there are behavioral health and crisis lines, and the 988 line is a prime example that's used in many states, and I'm glad to hear it's successfully used here. What we offer is the ability to bring all of that information into a central clearinghouse, if you will, across the state that then can allocate the appropriate resources in real time. And the beauty of that is that it can be geographically bounded. So for example, if there are certain areas of your state where faith-based detox and rehab is the most important opportunity for that patient, then we can say in that geographic area, if a call comes in via 988 and the most important thing for that patient is to get to that faith-based detox, we can make that available. Whereas if in other areas of the state that's not available, and it's more reliant on a private clinic or it's more reliant on a critical access hospital, we can match the capabilities with what the patient actually needs, which is the transformation that we think is possible. So if we think about it just from the 911 center, the slide number 16 takes us to the traditional 911 response that we were talking about. That's the system that we kind of force everything into, and that's called Patient Diversion Activity 2 is what it should be at the top of that slide, but it's slide number 16. And you can see it now on the screen. So this is what happens today. This is the system as designed back in the 1960s that is yet to be changed. What we believe is now on slide 17, start with the 911 center. We now know based on what the patient says, what their smartwatch sends in, all the information that comes in, that these patients, some of them can go directly to a nurse triage line. And this is happening successfully across the country today. As a matter of fact, in a couple of places where this has happened that have fully reported out, the patient satisfaction scores are higher when they go to the nurse advice line than they are when they stay in the traditional 911 system, which you might imagine if you're going to a hospital waiting room and end up in a waiting room and have to wait long periods of time, whereas your care is coordinated from your home, there's a benefit there for that group of patients. And then importantly, if we think about slide number 18, which is one I really want to focus on for a moment, is we now know that there's those patients that call multiple times, the high utilizer patients. Just like the high utilizers of the 988, there's high utilizers of the 911. And now that we can identify those prospectively, we can prescribe a different pathway for those. And there's two groups of those high utilizers that I think are important for us to reflect on. One group are those that call 2 to 5 times a year. Those patients are having progression of chronic disease. Those are diabetics that are worsening, congestive heart failure that's worsening, et cetera. So we now know once they've called that third time, they're likely to call 2 or 3 more times in that year. And we can start a program to go to the home, make sure they have the medications they need, do the things that would keep them out of the 911 system. Once you call more than 6 times a year, you're in a different group. Those patients are more likely to have a socioeconomic determinant of health issue, mental health, substance use disorder, et cetera. So those patients need a different set of interventions, and we can identify those and move those forward. And that's what the orange bar here is at the bottom of this graph, is the ability to prescribe in a very evidence-based way how to help those patients stay out of the 911 system. And when we think about the sustainability of such a program over time, this is how that comes into play. Going into the emergency department for treatment is obviously the most expensive way to provide treatment in the healthcare system. And so if we are able to move appropriately a subset of patients to some other site of care that gives them exactly what they need, but takes them out of that most expensive pathway, there are savings generated there every time. And that creates a sustainability plan for the program. I also want to note that even if you go to the emergency department, this allows that emergency physician to have different levers to pull besides admission or transfer. The ability to think about a hospital at home program to have the blood sugars checked on that diabetic by a community paramedicine provider twice in a day, as an example, allows the clinician to have maximum flexibility rather than everything needs to be transferred and we occupy resources and beds and so forth and so on. So the last thing to say about this part is one of the things that we at ESO like to provide is all of the reporting so that you know the savings or the not savings, is the program working or not working? So the stakeholders have that readily available. This is not a trust us, we've written a report 5 years ago. This is what's happening now in your community to see how many patients that used to go to the emergency department 12 times a year now go 4 times a year. And survey those patients and say, how is that opportunity availed to you? Is that better care for you? And then monitor for their outcomes. Do they have better health? Do they have less frequent diabetic crises, et cetera, et cetera? So the concept here is to think truly about this emergency medicine, rural and EMS transformation in an evidence-based way. Our role that we would like to suggest, and we're not asking for any action here, right? This is just simply information. But the role that the data can help us play allows us to be evidence-based in the way that we go through that transformation and create sustainability on the other side while making sure patients have the right care at the right time. The last thing that I would like to talk about is slide number 19. It just gives the actual software. I'm not going into the details of this because that's not the purpose today. What I do want to say is that we are vendor agnostic, meaning we're not here to say, whatever software is working today, we need to replace that. That's not the goal, right? Our goal is if you have software that's working in your hospitals, great. If EMS has software they like that's working, great. We can accept those data and create these reports and provide this oversight for the program in a way that we think is meaningful. The beauty of all of this is that this is in play today. This is the way that FEMA responds using our software across the United States. They overlay this across 911 centers when they respond to a hurricane, when they respond to other national disasters. The EMS response component is coordinated through a program just like this with our software. And so the notion here is to say, let's take that same concept and apply it to rural health transformation and move patients in an evidence-based way as well. So we go into details of your actual proposal that are on slides 20 and 21. We're happy to dive into those if you would like, but I think hearing the update earlier came after these slides were created. So I think, we can comment on the update that came earlier from the Secretary's office, and I will pause there and take any questions or comments. And I really appreciate the opportunity to present. Thank you so much.
Thank you. Senator Scott?
Got it. A series of questions on to the extent of which this really applies to Wyoming. First, a technical point. On the very first of the slides that were passed out, there's a thing that says proprietary and confidential, do not copy or distribute. That's not appropriate for a legislative committee. Once it's passed out here, it's public.
Yes, sir, that is a template, and I apologize for that. Please
Yes,
share it
I thought
publicly
that
wherever
was
you would
really
like.
just a
Yes, sir.
boilerplate thing. My question is, this state is larger than all of New England, has the smallest population of any state in the United States. And we have just vast rural areas, and many of them, the only medical services open a good part of the time is the emergency room. And I gather you're from a much more populated eastern state. What difference does our very sparse population make here? Does it remove some of the needs we have to screen some of these calls?
Great. Thank you, Madam Chair, Senator Scott. I think there's a couple of things to reflect on here. The first is, yes, I am from the East Coast, but I did grow up in rural Appalachia. So I do have a little bit of the rural perspective.
They're much more densely populated than we are.
Yeah, indeed, indeed. The second piece of that is all patients that repeatedly use EMS have the opportunity for an alternative pathway, whether that is with a fixed clinic like might be available on the East Coast, or whether that is a telemedicine visit that covers a community, or whether that is the EMS agency that's in that community providing community paramedicine to those individuals, which is happening across the United States in rural, urban, and super rural areas. So in a super rural community, there's a diabetic as the easiest example that needs their blood glucose monitored, rather than waiting on the urgency of the blood glucose being way too high or way too low. If there's a proactive opportunity to check that blood glucose by somebody in that community that can be identified, we can keep that patient out of the emergency department, as an example. Your point's well taken in that in other situations in the rural area, the concern is not keeping them out of the critical access hospital. Maybe they've got capacity for that. But the question comes, can we appropriately avoid an unnecessary transfer into a secondary hospital, here in Casper and Cheyenne or wherever that may be? And the opportunity to have evidence to support that critical access hospital to keep that patient safely in community is another opportunity here. So you're right, it is not one size fits all across the United States, and it's likely not one size fits all across the state of Wyoming. But it's related to the resources that are available in that community, and these are tailored. So your point's very well taken.
Further questions? Anybody? Representative McCann?
Thank you, Madam Chair. I'm in the medical field too. So in one thing, you have to practice defensive medicine, unfortunately. So I'm wondering how much lawyer proofing has been done to this.
Madam Chair, Representative McCann, I appreciate the question. We believe that there is risk the minute the 911 phone rings, right? That no matter how this happens, you've incurred risk by that request. We believe, and we're not attorneys, but we believe that the risk is best mitigated if you have the most evidence to support the response that you put forward. And so as a consequence, we have taken millions of patients that are from all of the different demographics, super rural, urban, and suburban, and then stratified the risk that comes based on the various types of responses. What's not discussed very often is you also have a limited EMS resource. And so if I take the response to that first call that the evidence tells us doesn't really need a time-critical ambulance, and then the motor vehicle crash occurs or the heart attack occurs, and my resource is already committed, and I have a long response from the next community over, what have you, there's risk associated with that as well. So there is, unfortunately, no such thing as lawyer proofing it, I think. I think we can approach it with the best patient care in mind, and that, to me, at least, is the best defense for that. But your point is very well taken. Anytime you change what has historically been the standard, whether it was evidence-based or not, there's going to be someone that may try to make hay out of that. And our opportunity, we believe, is to demonstrate via evidence in very similar communities across the United States that this is actually the best evidence-based approach. But I really appreciate the question.
Thank you, Senator Hutchings.
Thank you, Madam Chair. Mr. Myers, just a quick question. A couple of them were already answered by the previous questioners or legislators. What's the annual cost of a program like this?
Senator Hutchins and Madam Chair, thanks for the question. That is totally dependent upon how much we need to invest within a state. Our goal is to make sure that this is not a burden, that this is not such a cost burden that it prohibits it. That is not my side of the business, so I don't want to overcommit there, but we can, if there is interest in the pricing range that would occur for a statewide initiative like this, we are happy to do that in a rapid fashion. This is, information here. Once we see the RHT, we're more than willing to do that and be very transparent, but I don't want to overcommit that because that's not my side of the business, but we do have someone that does that and we can get you that answer very quickly.
Thank you, sir.
Any further? Co-chairman.
Thank you, Madam Co-Chairman. Mr. Myers, it's good to see you face to face. I appreciated the phone call and backup information earlier on. This is a very interesting topic and possible answer to a lot of our concerns with rural health and providing those services. One of the things I was wondering about, if you could say, is looking at a state like this with so much rural and so much land, would the services be available and be possible to, like in a county, we may have 10 different towns. We have volunteer fire companies. We have all of those things. How do you know how that might work? Just a snapshot.
Yes, Madam Co-Chair, thank you so much for the question. Yes, the beauty of the way that we have designed this is we build upon capabilities, not individuals. So for example, if we need in a particular community someone that can check a blood pressure, check a blood glucose, and then report out to a telemedicine physician, that could be a volunteer firefighter that's trained, that could be a local EMT, that could be the ambulance, that could be a local volunteer nurse from a faith-based organization. And this can be geographically walled off as small or as large as you would like it to be. And I've had the opportunity to use this for another kind of statewide initiative. And in that particular initiative, the goal was to keep patients from going to the hospital for routine labs and blood draws. That was the program in that particular area. And so we had a mobile list of individuals that could respond, and they started with PAs and nurse practitioners, and they ended with just standard phlebotomists and everything in between. And the bounds of the geography and the cost of moving the patient that far or moving the provider that far guided what resource was sent to that particular residence when that came. So if it was across the street from the PA's office, we might send the PA across the street, but we weren't going to send the PA 100 miles. That's a pretty valuable resource to move that far. We would find something in that local community that was in the program. So it is very flexible based on what's available in that community to hold certain capabilities, and it can be time bound so that you don't send someone, 120 miles for a relatively simple intervention. So yes, ma'am.
Thank you. Mr. Myers, just to follow up and for a point of clarification. So what we're looking at then is to have a network of providers rather than community 911 or emergency calls or sheriff's departments. Is that correct?
Yeah. Madam Co-Chair, I appreciate the question and the opportunity to clarify that. So we provide the data that supports the type of response that is needed. And obviously each community would endorse that data or no. And then we network into what the resources are that are available. We don't intend to supplant 911 because many times that is the most appropriate response. Our goal here is to expand the opportunity beyond simply an ambulance going to the patient and taking them directly to the emergency department. So whatever that request is, again, it may be that volunteer firefighter, it may be the nurse, but our goal again is not to supplant anything that's there, but rather to offer other options for patients besides going into the emergency system when that's not the best site of care for them.
Any further questions? Thank you very much. I appreciate it.
Thank you.
As an ICU nurse, a lot of times we see things that sometimes could have, with the right resources, could have been prevented earlier on, I think. So, okay, I'm sure that there are other groups here in the room that wish to testify on some of this rural health transformation program. So you guys can come on up and start filling the chairs on all things that related to rural health transformation program. Welcome.
Madam Chairwoman, my name is Nick Agopian. I represent the Wyoming Dental Association. Here today to talk about the Dental Practice Act and the discussion around the expanding the scope of practice for dental hygienists. And so I was here last before the committee. I think it was back in March. Feels like quite a bit of time has passed since then. But just identifying that when this issue was brought forward, we identified that we would want to be a stakeholder. My goal today is really, again, to affirm that this changing the scope of practice opens up the Dental Practice Act, and that's what regulates us as dentists. And so we're here today really wanting to identify as a stakeholder at the end of the day, and that we would look at this as there's a variety of ways maybe to look at expanding the scope of practice, and certainly would intend to be the most constructive we can if the committee decides that this is a priority that they want to move forward. We heard today from the department that they don't have a position on this. This wasn't an initiative that they brought forward. As I go through the application and I look at what some of those priorities were from the outreach that was undertaken, I think it was 30th was retain and attract dentists and dental hygienists. And then the discussion around scope of practice was somewhere around the 18th priority that they heard from the public. But at the end of the day, the application itself and the standard for scoring is there. And it's a state policy action. The governor's office, the executive has achieved their goal by bringing it in front of you as a committee because it does require a Practice Act change to expand that. The question then really becomes, are we changing the scope? Are we looking at changing the scope of practice to address providing services in a public health setting? Or we look at changing the scope of practice for what we have currently in Wyoming, which is the doctor-led model for private practices, where all hygienists today are in our offices providing services. And so I think that's a really big distinction as the group goes forward and thinks about this, and would hope that that information would come forward and be brought in front of the committee, because our statute today already envisions an expanded scope of practice for dental hygienists performing services in a public health setting. And just most recently, our association worked with the Primary Care Providers Association to go in front of the Wyoming Board of Dental Examiners, who regulates and licenses hygienists and dentists, to affirm that the services that the community care providers are providing today and able to provide with the practitioners fall within that community health exemption. The board was very gracious in taking the time to review the position of the primary care providers and affirmed that the practice, what's being provided in that expanded scope of practice, is what is envisioned today currently in the law. And so if we're talking about that expansion from what we heard from 2 practice areas to 8, I think there's a lot more detail that goes in those 2 to 8, moving from 2 to 8. And so as we start talking about that, it's important to understand what those impacts are. In the document for the scoring that's in the application, also makes that distinction between providing services in a public health setting versus in a private setting. And so going through those intricacies, understanding what that is, figuring out, what will and won't work here in Wyoming, what are the impacts on the public health side, what is there a net positive impact on the private side? These are really big questions that impact my clients and their small businesses. See, I had a few. So going forward, we would hope that we would hear more from the Board of Dental Examiners, hear more from the Primary Healthcare Association, would be key in having this discussion if the committee moves it forward. We really do need to understand better what that real needs case is and how this is really a solution. And then as we look for that solution and we talk about that scope of practice and you read through the application, it's really, as I read it, designed to ensure that the individual that's licensed or trained is using all of those skills in their actual practice at the end of the day. Typically, the hygienist programs in this state are in Sheridan and in Cheyenne today through the community colleges, graduating somewhere around 40 students a year. But the question then becomes, what my experience with community colleges is somewhat limited, but I do believe that a lot of our training programs are geared specifically to state practice standards. And so if we're going to talk about an expanded scope of practice, asking the question about what is that subsequent training need to go along with it? Where does it make sense? And then this really takes us to what we as dentists identify as the biggest issue associated with hygienists, and that's a shortage. And we have a shortage. With the community colleges only graduating 40 students a year, that's a very small pool for us to look to statewide. And the potential to make, is this, in asking these questions about expanded scope of practice, are there new training needs? What are the goals we're achieving? Should we also be talking about bolstering the community colleges? Certainly at a very high level, the Rural Healthcare Transformation Program envisions working with community colleges to address these workforce shortage needs across the state in our healthcare industry. And so I would hope that we would also potentially look at how the committee could direct over the next 5 years some investment in these community colleges. We've identified here in Casper, I think, the need for another training program. Those training programs typically cost around $1 million of just straight equipment to get in there. That you need a large capital investment, and then you need to find a trainer, somebody that's able to dedicate and dedicate to being in that position, and because they can do about 20 students in a cohort per trainer per training room. And so thinking about some of those things, is there an opportunity to have that discussion to look at as the state is revising and evolving with this program going forward? How do we make some of those investments? So I think I just said a whole lot to the committee, so forgive me for that, but I certainly would stand for any questions, and again, would identify the desire to participate in the discussion if the committee decides it wants to move this forward.
Okay, committee, any questions? Yes, there's lots of questions. We'll start with Madam Co-Chair.
Thank you, Madam Co-Chair. Mr. Agopian, it's
Yeah.
good to see you and always talk. Over the last few years, we have spoke on numerous occasions about dental practices, and a lot of times it's kind of sloughed off as not really important. But just thinking about it, this day and age with the workforce shortage that we're looking at and healthcare, dental care is so important to overall health in people. If you have a lot of dental problems, you have health problems. And I don't think we always see that. And I've even been made aware that plaque can actually cause heart disease and different things like that. So with workforces and people a lot of times having bad dental care and a lot of tooth problems, what I'll say is I really see the necessity to look at this with the transformation, because we have a lot of people just looking in looking in restaurants, looking in fast food places, looking in the unemployment office. There's people that can use this. So if we had more providers, possibly it would be more available. So I just want to thank you for being here and just say, you know, it really is something we need to look at.
Madam Chairwoman, I agree. This is it. Dental health is very important. And what we're seeing certainly with the primary care provider model here that's utilizing, I think, a lot of Medicaid dollars is they're now able to integrate some of these dental cleaning services in their facilities. And then as part of that, what we currently have in statute is for those expanded services, the individual providing those expanded services establishes a collaborative agreement with the local dentists. And so then we know exactly where to refer that patient when the needs of that patient exceed the skill set of the provider in that moment.
Okay. Further, Representative Rodriguez-Williams.
Thank you, Madam Chairman. Mr. Agapia, I appreciate your willingness to go further downstream and talk about the community colleges that are training this occupation, specifically dental hygiene, and it is limited in this state. There are only so many seats for students in the community colleges. I guess I would ask, or I would entertain a question to the department. And when we talk about funding for the rural transformation, is it possible really to allow investment in our community college to meet these workforce needs, given the expansion of suggested expansion of practice in this field? I'm just curious if that's feasible, because it makes no sense if we're not looking at the community colleges, the expansion of curriculum to make sure that these students are being trained in what's asked appropriately and what's asked of them through this grant funding. Is investment allowed for that?
We have an answer from the department, or a response at least.
Madam Chairman, Representative Rodriguez-Williams, there are elements of the rural health transformation that are focused on individual education and community college and other educational institution components of education. I would say that the educational institution components are more flexible as far as what kind of funding might be allowed to go into various areas like dental hygienists. The individual education awards, however, are limited to the highest priority things we saw from the community feedback, which would be nursing, EMTs, primary care physicians, and other providers. So it did not include or contemplate dental hygienist slots per se in our application.
Further, who was Senator Scott and then Representative Costin.
Madam Chairman, one of the populations that I perceive is most in need of the dental hygienist service is the nursing home and assisted living populations. And at one point, one of the nursing homes in my district had a program within the nursing home that they were able to service at that point because the individual they had claimed was licensed both as a hygienist and as a registered nurse and was able to practice independently on that basis using the facilities that the nursing home had available. If we do get into a revision of the Practice Act, one thing I would ask if y'all could think about, are there obstacles in the Practice Act to other
Madam Chair, it's my understanding that today those would be termed as a public health setting and would currently fall under the existing exemptions in the statute that allow the hygienist to perform within an expanded scope of practice in those specific settings. If you were to open up the discussion we most recently had with the Primary Care Association and Board of Dental Examiners, is we have affirmation now, but there's some ambiguity between the way the statute is written and the rule is written. And looking at this component and the statutory authorization already for public health expanded scope may very well be able to be addressed at the regulatory level, not at the legislative level, depending on how far you want to expand the scope of practice. A lot of the discussion this morning was around sustainability. And that really begs the question, is going from 2 to 8 sustainable? The application process and scoring process itself envisions a sliding scale and the opportunity to determine what fits best for Wyoming. Not necessarily what's black and white on the application, but how does it look when you write it in brown and gold at the end of the day? And the ability to still capture funding based on what's sustainable and what's going to work in your community across the state. And so I think, there's a lot of opportunities to Representative Rodriguez's question. And certainly I would stand to be corrected, but in tying those in working with the community college on improving a workforce initiative, and the equipment or the investment is tied to the net positive outcome at the end, I think is really that key to making that expenditure occur. I'm certain that it's more complicated than that, and it may not be the thing based on the existing application in year one that the state is ready to address immediately, but making sure that we don't miss the opportunity to have the conversation about the investment, I think, is really important.
Follow up?
Yeah, follow up, Madam Chairman. So what I hear you saying is you think the Practice Act will now accommodate that particular kind of circumstance where they wanted to do some practice on site in a nursing home.
Madam Chair, yes, Senator Scott, yes, I believe today that the Practice Act, if it's defined as a public health setting, the exemptions allow those services that are currently being offered at this point, to the best of my knowledge.
Madam Chairman, if we do get into it, we ought to look at that particular issue.
Thank you. Okay. Representative Klauston.
Thank you. So Senator Scott really covered a lot of my same questions, but I guess what I'm trying to envision is, I don't see it in the Practice Act. In Wyoming, is there a limitation on the number of hygienists that one dentist can supervise? A lot of states or other professions, there's that. I'm not finding it in our Wyoming Practice Act. So just something to consider there. But, I'm envisioning where maybe we have a mobile dental unit of hygienists that go to the nursing home, that go to people's homes throughout the state. They don't necessarily need a dentist with them. I mean, is that something that can happen? Do they need on-site supervision, or can a hygienist go out and do under general supervision?
Madam Chair, to my knowledge today, that scenario, if it falls under that public health offering, and they're adhering to the law and having in place a collaborative agreement with the dentist, so the dentist knows they're out in the community and what they're doing, who they're seeing, and there's an expectation for follow-up care. That's really what we're talking about. I believe that they're able to do that. The details of the funding and who's receiving those services probably ultimately dictate whether it is or is not, but I don't know if I could ask an expert, but I'd hate to put my arm around him and call him a friend if I accidentally answered that incorrectly. But I believe it does.
You can follow up.
Follow up. So yeah, that's where the question was leading to. So Franz, if you can answer that question, are these services that Medicaid or Medicare would cover if we were providing dental hygienist services in one of these settings?
Madam Chairman, Representative Clouston, I'm not exactly sure as to Medicaid's policy now, but we would certainly, if this was allowed broadly to meet the intent of this, this federal intent to allow the scope of practice expansion, you could certainly create whatever or work with LSO to draft whatever language would authorize that in Title 42.4, which is where all the Medicaid authorized services are. But we can certainly get back with you as far as what Medicaid's policy is currently.
Go
Madam
ahead.
Chair, and I do believe that, as I mentioned before, some of the services that are being provided and paid for under that Medicaid umbrella, at least in some of the, as I understand it. And so I don't think it would be a huge leap to make that change.
Okay. All right. So if we could just have some more information on that, a follow-up, that'd be great. And I'm going to go to another question from Representative Rodriguez-Williams.
Thank you, Madam Chairman. A question for the department. Obviously, there's a lot of, as you mentioned, controversial suggestions from the federal government, and Wyoming is unique. I don't believe, especially with the dental hygiene topic, that services are going to be provided with the shortage that we have across the state. Looking back at our community college and the programs that we have, the number of seats that are available. I have a loved one that was interested but actually went out of state because it's so competitive and there's only so many seats allowed. And so I don't know if the goal is to have like some sort of subcommittee to really bring stakeholders to the table to talk about, what this looks like for Wyoming as the committee considers these recommendations from the feds. Just curious what your, I would say, goal or our vision would be when it comes to that and bringing really everybody together to talk about these versus coming in front of the committee continuously.
Madam Chairman, Representative Rodriguez-Williams, I will say that the application was drafted. This particular component was drafted or put in there in the spirit of trying to maximize our federal award and not close off any opportunities. I will say there was not as much thought put into this particular item as there was, for example, the hospital or EMS. We figured we'd at least say we're going to bring it to the legislature for consideration, and then we'll figure it out at that point. So I think to your point, if this committee chooses to appoint a subcommittee, we're happy to work with that committee to try to work with stakeholders to figure out what the best way to accomplish this is. But I will be very frank and say that all these state policy actions were part of the spaghetti that is on the wall, and that was part of this application. It was not a central component of our application.
Go ahead.
Madam Chair, if I could just offer a great time to restate the importance of including the Board of Dental Examiners. The state's already established who the regulator is in this space, and making, their ability to convene and participate, I think would really be at the forefront for having that discussion, and then being able to provide that insight about the impacts on the practices, the impact on patient safety, and the potential going forward as we look to find a net positive benefit.
Any further questions? All right, I do have a couple of questions, probably for the department. How much, and if you don't have these answers, you can get them to us. How much money are we looking at? Like, what would be the effect of the dollars? Should we look into this and change some of our laws? And then does it make a difference on, we've got 2 of these 8 items. Does it make a difference on how many items that we do change in law? Should we go that direction?
Madam Chairman, we'll certainly get back to you. I think we can do an analysis on the dollars for each of these state policy actions that we may forego in an upcoming award if we do not implement them. We can certainly get back with you more details on that. On your second question, again, my initial reaction is that these are not going to be measured in a very nuanced way. My suspicion is it's an all or nothing. You do all of these 8 things, or we don't check the box and you don't meet that metric. However, I will confirm that, and we'll get back with this committee on that particular detail.
Thank you very much. Committee, any other questions? All right. Thank you very much. Welcome.
Thank you, Madam Chair, Madam Co-Chair, and committee members. I'm Melinda Carroll. I am here representing the Wyoming Pharmacy Association, the other uncomfortable topic that was on there, expansion of scope. I appreciate you all listening to this and considering it with an open mind. We would also like to thank you all for passing Senate File 121 this last session. That was a step in the right direction. However, we do need more statutory change to really make the strides that Wyoming needs to help the rural population. So I would encourage the legislature to consider modernizing Wyoming healthcare delivery by allowing pharmacists to practice to the full extent of their education, training, and experience, an approach already adopted by states to the west of us, the south of us, the north of us, and a couple states over east. So not a new concept for sure. With a strong, they all have strong safety profiles. We can address the challenge that Wyoming can no longer afford to treat as a hypothetical, a growing gap between patient need and timely access to care, particularly in primary care and rural communities. Despite having a trained and licensed healthcare workforce already embedded in those communities, the statutory language that is currently in place does not allow those healthcare providers to act within their training. Defining the practice of pharmacy in broad terms, including patient assessment and for the purpose of prescribing and initiating pharmacist care services in statutory language would be helpful. Why is this important? Wyoming is projected to face a shortage of more than 330 physicians by 2030, including over 100 primary care providers. Today, 20 of Wyoming's 23 counties are designated primary healthcare provider shortage areas, where patients routinely face ratios of 3,500 or more patients per provider. These shortages are not abstract. They translate into weeks or months-long wait times, delayed diagnosis, avoidable emergency department visits, and growing physician burnout. Nearly 30% of Americans do not have an established primary care provider, and many who do are unable to obtain timely appointments for routine or acute needs. At the same time, Wyoming already has more than 500 licensed pharmacists, many practicing in community pharmacy locations that are open evenings, weekends, and without appointment requirements. These pharmacies are often the most accessible and sometimes the only healthcare sites available in rural and underserved areas. Why the standard of care framework works? Standard of care does not rely on rigid task lists or narrow protocols. Instead, it allows implementation of the practice of pharmacy being defined as not limited to. This is consistent with other care models and other care approaches and other practice. I would like to note that the practice that regulates physicians, nurse practitioners, and physician assistants fall under this framework of a standard of care. Pharmacists may provide care consistent with their education, training, and experience would be what we would want, and that the profession regulates what that is. We already have a regulatory board in place. This model has already been implemented in several states as mentioned, and it does not reduce oversight. It aligns accountability with clinical reality. It regulates outcomes rather than paperwork and allows care to scale based on competencies rather than statutory or regulatory micromanagement. Importantly, standard of care does not eliminate collaboration with physicians. It ensures that collaboration occurs when clinically indicated, rather than being mandated as a legal prerequisite many patients cannot practically meet. Are we capable? Pharmacist education supports full practice authority. It is appropriate when a profession is trained and exercise clinical judgment. That condition is clearly met in pharmacy, as all pharmacists must graduate from a Doctor of Pharmacy program accredited by the nationally recognized accrediting body. Pharmacist education includes 4 years of doctoral level training with a minimum of 1,740 hours of supervised clinical patient care, covering patient assessment, diagnostic reasoning, laboratory testing, medication administration, therapeutic decision-making, and prescribing. For context, some counterparts are only expected to complete somewhere around 750 hours of training. This is improving access while preserving clinical coordination. Pharmacist-provided care expands timely entry into the healthcare system rather than fragmenting it. If implemented correctly, statute regulations could allow us to prescribe drugs and devices that treat conditions promptly and refer patients when clinically complexity exceeds the pharmacist's scope. This approach preserves physician capacity for complex cases, reduces unnecessary emergency department utilization, and improves continuity by ensuring patients enter the healthcare system earlier rather than later. Permission-based models such as collaborative practice agreements have proven difficult to scale, as they often require an existing physician relationship and impose administrative burden on community pharmacies. This approach is also aligned with federal healthcare policy. Centers for Medicare and Medicaid's administrator, Dr. Mehmet Oz, has publicly identified pharmacist prescribing as a practical solution to primary care access constraints and provider shortages, particularly in rural America. More importantly, CMS has operationalized this position under the Rural Healthcare Transformation Program. They explicitly rewarded states that have this expansion of scope a greater amount of money. If implemented properly, this could increase access to healthcare in Wyoming, especially rural Wyoming, where we know that it is important. Wyoming does not need to build new clinics or wait for a decade for workforce pipelines to catch up. The solution already exists in the community pharmacies and professional Wyomingites rely on every day. It is evidence-based, grounded in real-world outcomes, has a strong safety profile and clear accountability. With that, I would stand for your questions on this position, and I would also like to encourage the committee to consider something where we would have a work group where all stakeholders would be involved, as we want this to be a we solution, not an us solution.
Thank you. Committee, any questions? I have at least one to begin with. Do you know how many states operate under the standard of care framework for pharmacists at this time?
Thank you, Madam Chair. Currently, there are 4 states that are operating under a full standard of care operation. I can name those states if you would like. I avoided doing that. initially because I didn't know if that would be allowed in testimony.
I think that would be,
Okay. Currently, it is Idaho, Montana, Colorado, and Iowa.
all right. Thank you. Representative McCann?
Thank you, Madam Chair. Who determined this scope? I see this as kind of being a mid-level type scenario. And the key to being a mid-level is knowing your limitations. So who is going to determine that? As far as the other states, who determines that?
Madam Chair, Representative McCann, thank you for that question. It is generally regulated by the Board of Pharmacy, who has a 9-member board, 5 of which are pharmacists in Wyoming specifically. 1 is a physician position, 1 is a public member, 1 is a technician position, and 1 must be held by a veterinary practitioner or a dentist.
Follow up? Okay. I do have one question for the department, because what we have here is just pharmacist scope of practice. Is there kind of specifics that they're looking for as far as how that's opened up or not?
Madam Chairman, I might have to get my notes from my computer, but there was one, currently I think we're limited to, pharmacists are limited to prescribing vaccines, epinephrine and opioid antagonists. And this would essentially remove restrictions by class for prescribing. It would also allow pharmacists, the other requirement is allowing pharmacists to order lab tests as required. And I believe, I can confirm my notes later, but I believe those are the 2 major scope of practice changes.
Thank you. Yeah, that is what I expand the scope of practice by removing class, I do believe is what you guys said earlier. Can you expound upon that, like just a little bit, what that might look like? Because these are 3 very specific, like, and small classes.
Madam Chairman, I would, recognizing my limitations, I would certainly defer to the pharmacist here, what that might mean.
Thank you, Madam Chair, for that question. Currently, you are correct, it is limited, and we can only administer until you guys passed this last legislation, vaccines, which I know are controversial. I understand. However, that was what it was limited to. That did expand it. Starting July 1st, we will be able to administer epinephrine because previously we couldn't administer that unless in an emergency situation or, opioid reversal agents. However, those 3 classes were determined because of public health crises or public health needs. I would say that most people pushed back on those pretty hard, and those have been implemented in Wyoming smoothly without issue. There have not been complaints. What this would allow is for it to be open because currently I can run a cholesterol screening in my pharmacy with a CLIA-waived test. I do it frequently. I can currently run an A1C screening in my pharmacy with a CLIA-waived test. My problem is when I run those screenings, I have personal experience where I had a gentleman that had cholesterol with levels that were very concerning, over 400, which to my fellow healthcare providers is it is a number that any healthcare provider would find concerning. And I was unable to do anything about that other than say, I would highly recommend you go see your provider. If this type of legislation was passed, I could have done something then about it. I could have addressed that issue then with collaboration with the patient and understanding what he was comfortable with. I would be able to address the issue and initiate appropriate therapy. I am comfortable with doing that because I am very up to date on guidelines on lipid management, diabetes, hypertension, many chronic care diseases, and many other acute illnesses such as strep, influenza, urinary tract infections, viral prevention in general. Pharmacists are trained to do all of these things. We are not asking to do things that we know that physicians need to manage and need to manage those more complex cases, those more complex disease states. Pharmacists would not ask for that authority, nor would we want that. We want that to remain with the physicians. We are just asking to fill a gap in those areas that we are trained and that are quite clearly not filled in Wyoming.
Thank you. Any further questions? Representative Rodriguez-Williams.
Thank you, ma'am. Just to follow up to one of your statements, if you were to provide what you refer to as initiating appropriate therapy, say, for example, for strep, how would that work with insurance and providers in our state?
Madam Chair, Representative Rodriguez-Williams, thank you for that question. That's the question, right? Who are going to provide these services if we're not compensated for them? So that's a very valid question. Currently, pharmacies and pharmacists are able to go through medical credentialing, and we could bill their medical insurance instead of their prescription benefit management insurance. Ultimately, the drug would be billed through one, the services would be billed through another. So this would be an additional step that pharmacists would have to take on. We already have pharmacies in the state that have medical credentialing, though. They're just not able to use it to its full extent. So initiating therapy that was appropriate would be something such as diet, exercise, lifestyle changes always come first. And then we would talk about, intervening with pharmacologic therapy to help lower those numbers that high. Unfortunately, as a healthcare provider, many know it is not able to come down with just lifestyle changes.
Further questions? All right, thank you very much. Welcome.
Thank you. Good morning, committee. Chairman Brennan. My name is Jen Davis. I am with the Wyoming Primary Care Association. And I just wanted to give a couple of follow-ups. I know Mr. Agobian was up earlier talking about the Wyoming Primary Care Association and the work that we've done recently with the Dental Examiner Board, which was a really great experience. And I think we're really starting to develop a collaborative relationship there on talking about how hygienists are used within the public health space for the scope of practice. So just want to make a couple of clarifications around that. So the Wyoming Primary Care Association represents the federally qualified health centers in the state, which also are referred to as the community health centers. They are federally funded health clinics that have to deliver comprehensive care per federal regulation. They also have to offer a sliding fee scale for those individuals who are uninsured and don't have other means of accessing health care. Through that, they are required to offer either in their clinic or through a cooperative agreement primary care, which includes medical, behavioral health, dental, pharmaceutical. And so they look at the whole comprehensive picture of the patient, ideally in one location, but some of our clinics are really small and don't have all of those services on site. For those that do have dental, I would say Representative Rodriguez-Williams has made a really good point that it really is about the workforce. We do not have enough availability of dental hygienists in the state. Both of our current community college programs, as was mentioned, have limited capacity. Not only do they have limited capacity within how many students they can take within their program. There's limited capacity of who can precept those students coming out into the community. So it's multifactorial around the workforce. Both of those programs are also located in border communities. So we have what's referred to as the border bleed. The individuals come in from out of state, go back home, or they're in state and the wages are different in another state, and so they leave. So again, I think those are all things that need to be considered if you all choose to look at the dental hygiene scope of practice. We are fortunate to be able to fit into that community clinic perspective for the public health on the scope of practice, which is wonderful. But there are limitations even to that. One is workforce. The second is payer. Medicaid only has dental coverage for children, so there is no dental coverage through Medicaid for adults. Dental insurance, as probably many of you even know, is very limited. And so it's difficult. They see most of these patients on the slide because they don't have dental insurance. And that doesn't even begin to cover the cost of operating the service. So many of our clinics struggle to have that service because there just not is available payer sources to even pay for the hygienist. They would love to send them out to the schools, as Senator Scott was referring to, or to the nursing homes, but there is no payment to do that. So even if you can find a hygienist, we've looked at mobile clinics for Wyoming, I think is a great idea to get access to care. But again, there's no payer source for those individuals unless it's children. Oral health is extremely important, as Chairman Ottman mentioned earlier. Lots of times if someone needs an open heart surgery and they have a dental issue, they can't get their open heart surgery until their dental issue is resolved. Well, if they're not insured, where do they go? So it's a big issue, and I think it really needs to have a comprehensive conversation if you guys look at this. And as Mr. Gobian mentioned, having a comprehensive community stakeholder group that is doing the work in the communities help you with that conversation and help the department of, moving anything forward that is a requirement in the RHT. And with that, also want to add on, as Melinda spoke to about the increased scope of pharmacy. Our clinics also have pharmacy. Many of them have on-site pharmacy. And so it is a really important issue about how we ensure individuals are getting access to pharmaceuticals, where they can access that, and making sure we do a lot of work with our Idaho clinics. Some of our Wyoming clinics are owned by Idaho. And so have talked with them a lot about that increased scope of practice for pharmacists in Idaho and how they're managing particularly substance abuse through mobile, which is really innovative and has opened some doors that I think are not open in Wyoming. So again, I think it's an important conversation for you all to consider. But again, having the right people at the table that are doing the work, what those impacts would look like, both positive and negative, and then determine if that is the right move for Wyoming, with patient safety in both of those areas being in the forefront, making sure that people doing the work are trained and competent to do that, so that we ensure that people are getting a high quality of care with that as well. And the last thing I want to mention is the RHT, as there's been a lot of discussion this morning about the critical access hospitals and about EMS. Primary care is our avenue to controlling healthcare costs. And we really need to, and we're very fortunate, Department of Health did include expansion of that in the RHT application. But as we're having these tough discussions, even when we're looking at the amount of money that may come to Wyoming, utilizing it well and making sure that we're setting ourselves up for the future is a really great opportunity. And I would just really implore of this committee, we have to think about primary care. When we drive people to the highest cost facilities, which are our hospitals, and for right reason, as Mr. Fuchs had talked about, they have to be at a ready state, right? It has high fixed costs. We need to be sure that we're optimizing care at the primary level, incentivizing that, and funding it so that people are getting that care before it becomes an emergent situation and they're needing to access the highest level of care at the highest cost. So again, I think there's lots to think about. If you do all end up looking at the perpetuity in the bill that was passed in House Bill 122 last year, currently primary care is not in that. So I would ask that if this is something that the state considers for the future of how we might fund that in a different way than RHT, which is great for us to be thinking about healthcare long-term sustainability, I would really consider that we might want to expand what is in that and with a focus on primary care. So I would stand for any questions that you all might have.
Thank you, Mrs. Davis. Thank you for pointing out to the just the primary care and the importance of that and keeping up with that. And I think that access and affordability to primary care is it's an issue, and it is, when we don't have that, it does drive things up. The ER is not the cheapest place to get healthcare for sure. So committee, any questions? All right, thank you. All right, Ms. Bush, thank you.
Thank
Welcome.
you. Good morning. Thanks. Members of the committee, Sheila Bush with the Wyoming Medical Society, and also this morning on behalf of the Wyoming Academy of Family Physicians. Given the concentration on primary care, I'd like to just underscore what Ms. Davis offered. And I have a good bit of data and statistics that can support what she said in terms of reducing the cost of care overall, better outcomes when we focus and value primary care and its role. A few other things I wanted to touch on. Earlier, mental health was a big part of the morning's conversation. There is a new resource online. I've talked with a couple of you about it. It's fairly recent. The AMA partnered with the Kennedy Forum to create a mental health parity index. It's a pretty cool interactive tool. It's public. Anybody can go access it. But what it does is it takes the country, and you can narrow it down to the state, and then narrow further into the counties. It will show you total number of providers who claim a certain county or area as their residents using their NPI numbers, their National Provider Identifying Number. And then it will show you what our major payers are reimbursing when you compare physical health codes to mental health codes. It's a pretty interesting picture, and I think it's a really important picture that it shows because it further offers not only who those providers in the counties are, but then how many of them have actually contracted to be in network with any or all of the payers. And when you put those numbers together, I think it paints a really important part of the picture that goes beyond who's licensed in each area to provide services, but also if you have 100 individuals, providers of all types licensed in an area, that doesn't mean a lot to a patient unless they're available to them within their insurance. So I think as we talk about access, again, more tomorrow, we can talk more about it. It's a little clunky. It's an index, it's an interactive map, and so you have to kind of dig into it a little bit to use it well. But I anticipate it serving as a really nice resource as these conversations continue. And then lastly, I just wanted to underscore the Medical Society's interest in the pharmacy scope conversation. I think scope of practice conversations always make my heart race a little faster than I prefer, but they're really good to have. They're really important conversations. We want to be partners. The Medical Society believes that anything we do that further fragments care, drives up cost, and reduces health outcomes. And so we believe that the partnerships within the healthcare team are really important. And we'd like to make sure that the conversation underscores that those partnerships are really valuable. And the more that we take action in a policy sphere that serves to jeopardize or deteriorate those partnerships or the bridges built between the providers and the way they were really intended to function together, I think there's risk that comes with that. And certainly also sometimes reward. And you'll hear all of those sides of the conversation as I anticipate it continuing. But I just would like to offer that the Medical Society values pharmacists deeply. I think most physicians would tell you they could never do their jobs without them. And I think that the relationships between those provider groups are critically important. And so all of the conversations that happen in rooms like these should accentuate or put the relationship between those provider groups at the very top of the consideration. And what we do in a policy sphere, what dominoes does that push that ultimately 10 years from now, we might look back on and say, gosh, we could have maybe been more thoughtful about ensuring that those groups are really partnering and collaborating. I would offer that today in Wyoming, pharmacists can prescribe as long as they have a collaborative agreement with a physician. They're active in several areas in Wyoming. I think that they work really well. And the other last thing I would say is there's a difference. There is a pathway for pharmacists to become clinical pharmacists. At that point, they do residency training. I think that the conversation should appreciate and concentrate on the nuance between a clinical pharmacist and one who has not pursued that extended training. And so what might be appropriate in a policy conversation for a clinical pharmacist may or may not be different than those who haven't gone to that extended training. And so I just think that those are things to put in our pocket as nuggets to make sure we continue talking about. I would reiterate what Ms. Carroll offered is, a working group is probably a good idea, that we can all come together and really have these conversations, and people that know more about it than I do can be the one voicing the position of the physician community. With that, I'll stand for questions.
Thank you very much. Representative Clouston.
Thank you, Madam Chair. Thank you, Ms. Bush. Just curious, do you know how residents or fellows are paid in Wyoming as they're doing their training? And I bring it up because I know part of the rural healthcare funds can be used to help supplement those residencies and fellowships. So I don't know if you can answer that, or Mr. Fuchs, if you can answer that, but just a way maybe we could attract some more people to Wyoming.
Madam Chairman, Representative Clouston, I don't think I'm the best one to answer that. I think the limited information I have is in a family medicine residency like we have through the University of Wyoming and Casper and Cheyenne. If you're a first and second year resident, I believe you're billing underneath the tending physician's identifier or their code. And then I think once you're a third year physician, your licensure status changes with the Board of Medicine. And I trust that Director Bottomblest is here and will correct me. And at that point, I believe that they can pursue credentialing and bill on their own. So all that said is with an asterisk of I'm not sure. I will fact check myself, and I don't think that answered your question. Is that what you were asking? Is how those individual residents are paid, or?
Follow up.
Yeah, thank you. So really what I'm looking at is, can we use some of these funds to help pay residents and fellows as they train in Wyoming? Would that help us attract them? Because possibly we could pay better than maybe some of our neighboring states. So I was just wondering, how are they currently paid? So they have money as they're trained. And then could we use some of these funds to help in that aspect?
Madam Chairman, through you, thanks. I appreciate the clarification. I think that money's always a part of the conversation, right? And yes, I think the more you pay, the more competitive we will be. I would say before we get to what we're paying the residents, we should probably have a conversation about what we're paying our faculty. We're not paying our physicians who are operating within the UW family residency clinics, maybe what a competitive salary would be for the region. I think that deserves and warrants a conversation. I also believe that the facilities that they're in deserves a really big conversation. We know that people will remain close to where they train. We know that rural residencies across the country are fewer and fewer, and they're a critical component of training the workforce that's comfortable practicing in a rural area. It's very different to train in the heart of Chicago at one of the most preeminent, elite residencies, and then look at getting a job in Lander, Wyoming, where the kind of practice that you're going to have and the number of procedures you as a physician have to be comfortable doing is much different than it was when you were sort of guiding a team in a really densely populated area. I think those conversations are really important. And so I think what we should do is focus on our residency programs, the one that we have, and its locations, especially the rural training tracks, the one in Thermopolis and the one that's in conversation to be built out. I think those are so, so important. And supporting our faculty that are in the residencies, and the environment that we ask them to drive to every day to go to. So in the match that just completed in March, I think it's an important piece to know that as much as we invest in WWAMI, it's rare that a WWAMI student, even pursuing family medicine, will select a University of Wyoming residency. And it's multifactorial. There's no blame to be assessed, but I think it's worth a policy conversation and a really in-depth look at why that is. We're making a significant investment in the medical student side, and we're making a significant investment in the residency side, and the two aren't matching. And if the purpose of WWAMI is to incentivize those physicians to come back and practice in the state, and we know that the comfort level practicing in a rural area is increased by training at a rural residency, and we have one here, why is that connection not stronger? And how can we unpack that and do better?
Thank you. Any further questions? Do you have some
Madam Chairman.
comments? Yeah.
Representative Clouston, just to answer your question about the rural health transformation, there is funding for expanding specifically family medicine residency programming and slots for 5 years. We were intending to have that more perpetual, but right now the deal on the table will be for 5 years.
Any, and is there plans for where those slots would be at?
Madam Chairman, we would open up again, it'd be a request for applications. So we would not prescribe, we would just have an application and those programs would apply. Given that there's only, basically one, the UW practice that does family medicine residencies, and establishing a residency program is a difficult task. I would guess it would be that program that would probably see those slots.
Yep. Thank you very much. Any other questions? I will quickly kind of mention, because it was kind of touched on like, what are we paying residents and how does that work? I don't know if there's anybody here that can kind of explain better than I can on actually there's like a whole matching process that residents go through to get into a residency program. So it's not just like, it's a very interesting process that the residents go through to get matched. So it might be a student's first choice, but they might not get it. It's a very, very interesting complex. And I do see that we do have somebody who can kind of explain that a little bit, because it doesn't just come down to a dollar, but a whole bunch of factors.
Thanks. I'm Dr. Susan Sheridan. I'm an OBGYN practicing here in Casper, Wyoming. So the process of residency match is, like you said, quite complex. Resident salaries are set largely by GRME, the Graduate Medical Education Group, which is a national group that oversees all medical education of residents in the entire country in all aspects and all programs. The process involves applying to specific programs that you're interested in. It costs money for the medical students to apply to each program. So you, as a medical student, without sufficient funding, while you're a poor student, have to decide on how many programs you're going to be wanting to and willing to apply to. Historically, you had to travel to those programs on your own dollar to do your interviews. More recently, I think a lot of those are done virtually now, so that saves cost. But each program interviews the applicants that have applied to their program, and each applicant then ranks their programs in order. So if I've applied to 5 programs, I rank which of those 5 programs I want to be accepted to in order, and the programs rank each of their applicants in order of which applicants they want to have in their program. And some sort of computer matching program goes through and matches residents to programs. So in the aspect of paying residents more, I would be under the impression that the GME would not allow states to decide how much they pay residents. Residents don't apply to programs based upon how much money they're going to be making. Residents are paid a salary, a base salary for the expectation. And most residents work on average 80 hours a week based on work hour restrictions.
Thank you. I've not been through the process, so I couldn't explain it. Community questions? All right. Anybody else who wants to testify on this topic? Okay. Quite a few online? Okay. Let's go to online testimony then.
First up, I have Lindsay Simoneo.
All right.
All right, did we do the thing? Can you hear me?
Well, I can hear you.
Huzzah.
Welcome.
Hello. Hello, Labor. Madam Chairman, members of the committee, my name is Lindsay Semino with the Wyoming Behavioral Health Alliance. Forgive me for not being there today. I'm actually in Cheyenne tracking the Selective Gaming Committee. Since behavioral health was brought up earlier this morning, I just wanted to touch on some highlights, as well as some reminders of what we have accomplished in Wyoming to this point. The Rural Health Transformation Funding is a unique opportunity for Wyoming to address certain needs. And we absolutely did submit a proposal as far as what we think those priorities are. And we did that based on the work that the legislature had been doing in recent years. As far as the suicide lifeline, 988, I wanted to remind the committee that in 2023, we did pass the 988 Suicide Lifeline Trust. That trust, the legislation was so that there could be $40 million within the trust, and then the interest can be used to fund the call centers as well as additional services. As of right now, there is $10 million of general dollars within that trust. We are hoping this interim with discussions, whether it is with labor, with appropriations, or with the select gaming committee, to get that up to that full $40 million. As far as the grant with WASCOP that was mentioned, I was able to talk to Mr. Thompson earlier this week. I can tell you that that grant does expect outcomes, not just mental health outcomes, as well as outcomes for the officers and how that is supporting and how it's useful and the usability for the law enforcement across Wyoming. And so we will have that data coming from WASCOP. When it comes to the 988 Lifeline bill and legislation, there is language in that bill that includes that that the funding can be used for the Lifeline as well as mobile crisis. The definition of mobile crisis is very vague. And so we're actually hoping in talking with WASCOP that when this grant concludes, possibly are we able to then extend some of that? Would they be able to qualify for some of that funding? That is what we're in discussions with them. Compacts were mentioned. Yes, Wyoming is part of the counseling compact. We are hoping to go live this fall. What has been preventing us is we have been a pen and paper board since 2019. So all of our applications and renewals are through our pen and paper at this point in order to be compliant with the compact as well as with any future compacts. We need to become a digital board so that we can be compliant with that license mobility. And as of right now, I am being told that should be completed fall of 2026 for us, which means that we will be ready to set up that social work compact. Wyoming's very big on local control. And so we're working on mobilizing the social workers that seem very motivated to bring that compact forward, as well as the school psychologist compact. School psychologists are a member of our coalition and just completed their funding model advocacy for school recalibration, as many of you know. And so that's where their focus has been, but they are wanting to bring forward that compact in the coming months as well. And as far as faith-based organizations, I just would love to highlight, touch on that. I was outed. I outed myself as somebody who was clinically trained, my clinical counseling degree at Denver Seminary this past January. Absolutely, faith-based organizations are a part of this, and they are always a part of the behavioral health discussion. They are always a part of the behavioral health conversation. And it's in our code of ethics that faith and faith-based organizations are absolutely part of supporting the individual and part of creating the best outcomes for them. It is used, especially in the strengths-based approach. The way that I want to encourage the legislature is similar to whenever we are talking about a vulnerable demographic or a certain people group. Faith-based, as long as the group is meeting those evidence-based practices, they are involved in the funding model and the funding discussion. And I believe that's it as far as what we are covering. We did submit a proposal to the Department of Health when it came to the rural health transformation. And I want to echo my colleagues from the Wyoming Primary Care and the Medical Society. We very much believed that the one major issue in Wyoming when it comes to addressing healthcare is the workforce issue, whether that is the the integrated behavioral healthcare model with primary care, whether it is increasing education and educational opportunities. That is where we would like to see the focus of that money go. And with that, I stand for questions. Forgive me, that was a bit of a whirlwind.
Thank you very much. Committee, any questions? All right, thank you. Appreciate it.
Thank you, Madam Chairman. You guys have a good day.
Thanks.
Next, we have Dr. Marks.
All right.
Hello, everyone. It's good to see you all again. Madam Chairman, Co-Chairman Ottman, thank you for your time and this opportunity. As you know, I am Dr. Thea Marks. I'm a licensed naturopathic physician born and raised in Kinnear, graduated from Wind River High School. Many of you know where that is. You may recall that I've been in this committee before about licensing naturopathic physicians in Wyoming, but I'm here today because Wyoming faces real documented healthcare challenges, as we've heard throughout this day. And naturopathic physicians have concrete skills that speak directly to these challenges, and we add to the workforce. As the committee discusses rural healthcare transformation program, we ask that naturopathic physicians be stakeholders in these discussions. We know that Wyoming ranks among the highest states in the country for suicide. We know that we have maternal care gaps that leave women in communities without nearby support through pregnancy and after delivery. Substance use, including opioid dependence, alcohol use disorder, and benzodiazepine dependency is widespread and undertreated. And across rural Wyoming, patients are managing complex chronic care conditions, as we've heard from the pharmacist, the dentist, everyone today. And there's too few providers and too little follow-up opportunities. These are not separate problems. They all arrive together, and often they arrive in the same person at the same appointment. Naturopathic physicians are trained as primary care providers with NPI numbers. We complete 4 years of graduate level medical training after a pre-medical degree. In licensed states, we perform physical exams, order and interpret labs, prescribe medications, provide pain management, including injection therapies, administer IV nutritional therapies, and coordinate with a broader care team. We also bring functional medical testing, botanical prescribing, clinical nutrition, and prevention planning. A first appointment often runs 60 to 90 minutes, and this is beneficial in Wyoming because often rural Wyoming patients arrive without one clean problem. There are multiples that we are dealing with. And we also know that people in crisis rarely say they're struggling. They say things like, I cannot sleep. They say, I hurt all the time. They say, I have not felt like myself since I had this baby. And so let's talk some real life scenarios that we all know in this medical community. A ranch wife comes in exhausted. Underneath that, she is postpartum, isolated, and carrying something that she has not told anyone. With time we spend and the training we have, we can order her labs, review her meds, assess her mental health, and follow her closely enough to catch what might otherwise become a crisis.
A coal miner comes in for pain. The real story includes poor sleep, alcohol use, a medication meant to be short-term, and a depression he has never named. Naturopathic physicians are trained in monitoring and tapering opioids, benzodiazepines, and alcohol dependence with nutrition support, safety planning, and care coordination. If we only treat the pain, he really hasn't been helped. A grandmother comes home from the hospital with 6 medications and a discharge summary. Most of us know what this is like. Could be because she doesn't fully understand what has happened and what she's dealing with forward. So we sit with her, we review every med, we order follow-up labs, and we keep her well enough to keep her out of the emergency room. Nationally, let's talk about, switch gears and talk prevention, because nationally, type 2 diabetes diagnosis in children has increased more than 50% over the past 2 decades. 1 in 3 adults are at risk in Wyoming. So children do not become diabetic overnight. The patterns begin at home, in schools, around food, sleep, movement, and stress. Naturopathic physicians have helped develop programs such as Naturally Well, a national award-winning children's nutrition program to teach children how food affects energy, mood, learning, and long-term health. This is prevention work that we can do, and we do every day. Quiet, unglamorous, and it saves lives downstream. We know that Wyoming has a shortage of primary care providers, mental health practitioners, and maternal care support across rural counties. Naturopathic physicians are trained, licensed in states across the country, and ready to work within care teams and programs like we've heard about today. Rural hospitals, telehealth platforms, and prevention programs. Licensure establishes the standards that make all this possible: education, scope of practice, referral pathways, and accountability. The challenges that Wyoming faces are ones naturopathic physicians are specifically prepared to help address. We can support mental health care through longer appointments, careful medication management, and monitored substance use treatment. We can support maternal care through attentive follow-up, nutritional support, and postpartum mental health monitoring. And we can support rural primary care by bringing the full scope of our clinical training to patients managing complex, chronic conditions with limited access to specialists. And we can support prevention, reaching children and families before illness takes hold and before a crisis becomes irreversible. We could do more from Wyoming. I respectfully ask that this committee include naturopathic physicians in its future conversation as it looks at options for rural health care. Thank you so much. I stand for questions.
Thank you. Committee, any questions? All right, thank you very much.
Thank you.
All right. Ms. Gallis, welcome.
Hi, I'm Sheila Matthews Gallo from Able Child. I have members in every state. We do not take federal or state funding. We represent the public. We're not here to ask for any money. We attended the Mental Health Over Medicalization Summit in Washington, D.C. with Secretary Kennedy. And I want to go directly to a couple of points here that the Director of Health brought up. One, this is a one-year $205 million grant and then builds over 5 years. We absolutely support dental. We feel that it impacts children's behavior with 12-year-old molars coming in. Nutrition education. Why is that controversial? I mean, that is ridiculous that doctors aren't trained on that, so we support that. The fund, we absolutely disagree with stockpiling consumer funding and investing it. This money is supposed to go to the public, so we strongly oppose any fund where it becomes a slush fund for providers. Our concern is that there were 1,300 public comments for this grant, and that is a real small amount of public feedback. The behavioral health is the biggest issue we have. We came to your state regarding the death of a mother who killed her children. We tried to convince the lawmakers to pass informed consent when it came to psychiatric drugs linked to suicide and violence. We asked your state to increase informed consent for the consumer. So we are very concerned about the information that's being provided here by the providers of the 1-800 number for suicide, asking for more money on that when we don't even know how to track their outcomes. Are these people being pushed into psychiatric drug use? The same vendors that are coming before you today have refused to give you lawmakers the data of the deaths associated with suicide, which is on the black box drugs that you're trying to increase access. We've submitted two things to you here today. We submitted to you the spending gifted versus ADHD. Nowhere in this funding from the federal government have you chosen as a state, and I want you to consider this, tutoring for children. This is something that it directly affects behavior. So we are spending on ADHD educational services, which these providers are asking you for more money on, when the gifted children, their same checklist identifies exactly like the ADHD behavioral health checklist, and then they're trafficked into drug use. So we ask and encourage you to include tutoring. And we really want you to understand that the questioning of the survey that the director of health said he put out a statewide survey. We would like to know what the wording of that survey was, because again, 1,300 comments from the public. This money and all what you're trying to do here is to best serve the health of your members of the state. And by ignoring the link between psychiatric drug use and increased risk of suicide, and just continually giving this same model continued funding without getting the data from them, which they refuse to give you. You know, because I came to your state and the coroner refused to incorporate pulling that data from dead perpetrators of mass shootings, whether it's a mother killing her 4 or 5 children. So we ask that you support instead of telebehavioral health, we're asking that you incorporate in the wording educational resources, because communication directly affects behavior. So what we're asking you to do is rethink this model. You have a lot of money here. It should not go into a fund that is hijacked by the behavioral health providers. You could even look at the last behavioral health woman that said she had $40 million in the fund, and now she's looking to restack that with very bad outcomes for these people that are addicted. There's no exit plan, and that is what Secretary Kennedy is looking at. I ask you to incorporate that into this money to de-diagnose and give consumers the freedom to get off of these mind-altering drugs. We cannot avoid this conversation any longer, and it's just not fair to ignore the public. So with that, I'm so grateful that you have given me the opportunity to speak. We are not paid to be here. We are funded by parents across the country, many of which are in your state. So we ask that the public survey be released to how this was solicited for their comments, because I think that's really important. And then the assistant director of health that's here in your room with you, I would like to take a look at what he did say. He was going to be specific of how these RPFs, I think they're called, go out to providers. So we want to make sure that it includes informed consent. We have a bill that we'd love to talk to you about Parity exists. We're not saying it doesn't, but it doesn't mean that behavioral health, massive companies are the only ones that have cornered human behavior. And if we cannot question them and their checklists and how you keep using evidence-based when it is very subjective. Anybody could be diagnosed with any one of these behavioral things. So with that, I look forward to working on informed consent. You have to tell people that there's no chemical imbalance. You have to be honest with people and tell them that there's no way off these drugs safely until you passed Secretary Kennedy's de-diagnosing code. So I thank you for listening to me.
Thank you. Committee, any questions? Thank you for your testimony.
Sure, and I will say one of the members did bring up lawyers and lawsuits. The best protection against a lawsuit is informed consent. So thank you so much for holding this hearing.
Thank you. Do we have anybody else online?
Madam Chairman, I have Matthew Meyer, but he's declining the invitation to rejoin, so we'll see.
Okay. Mr. Meyer, if you want to join. All right. Welcome.
Hi, Madam Chairman, members of the committee. I'm Matt Meyer. I'm a pharmacist up here in Sheridan, Wyoming, and a small business owner. We actually own and operate 2 retail pharmacies here in Sheridan. I apologize for not being present. I didn't know about this hearing until just a little bit ago, but wanted to jump in real quick here and just support Melinda Carroll and the Wyoming Pharmacists Association in supporting the expansion of the pharmacy practices. And it's funny that that we mentioned a few things here earlier today. Just to clarify, collaborative practice agreements, yes, while they are available, they are very restrictive in terms of practicing at what's written in the document to just that scope. The other thing that it limits pharmacists to do is bill under their own NPI number. So when you operate in a collaborative practice agreement, basically you are assigning those rights to operate under the physician and again, bill under the physician's NPI number. Now, we are a medically credentialed pharmacy and currently are partnered with our addiction clinic here in Sheridan to operate their buy and bill for their administration of long-acting medication-assisted therapies for opioid and alcohol dependency. And all pharmacists work very, very closely with primary care providers. And by expanding the Pharmacy Practices Act, or our scope of practice, excuse me, you know, you're not looking at taking that communication away. This isn't something that we want to expand our role and services as providers to take away from physicians. I mean, the physician still needs to be the very center of the care team. But like we say, you know, Wyoming's not attracting new providers and definitely having a hard time meeting those needs in a lot of areas. And one thing that we do have and people have, Wyoming residents have access to, are community pharmacies at this time right now. So just like nurse practitioners, this is a spot where we could step in and assist and fulfill those roles on some of the more simple chronic care management, transitional care management, while keeping the physician and at the very center of the care team, making sure that Wyoming residents are getting access to healthcare providers and making sure that their primary care providers are in the loop and well informed on the patient's care that they're receiving. And just on one final other note, one thing that we hear of, and most pharmacists will tell you, is there's always this term called corresponding responsibility, which always kind of makes me smile a little bit. And the fact that as pharmacists, you know, we have a corresponding responsibility to the health and safety of the patient, in their management and their care, and are often, when there are problems, and legal matters, are often brought into that legal arena, and yet at the same time we're being held to the liability standpoint, but being denied the opportunity to provide the services or seek reimbursement or compensation, for those services that are being provided, which again, I mean, they are currently available. We have gone through the medical credentialing and do utilize E&M billing and medical billing in order to provide a lot of the services that we do. So, you know, the term clinical pharmacist, I would love to see that definition and to see who wrote that, because residencies are truly for specializing in things such as emergency medicine, pediatrics, geriatrics. Granted, I've been out of school for a little while, so I'm not sure if they do have a clinical pharmacist residency or not, but I would love to know what that entails, considering, you know, what we do every day, day in and day out, what determines what's a clinical pharmacist and what's not. So, expanding laboratory ordering to our scope of practice actually makes a lot of sense. I mean, we're there to manage medications and are supposed to be, the medication experts, let's just say, as we're constantly told. But yet we don't have the authority to order simple things such as lab tests to monitor their safety and efficacy, of those medications that are being prescribed. So, with that, I think a working group and further review and multiple stakeholders would be a great thing, to evaluate, how we proceed with the rural healthcare transformation, in terms of how pharmacy can step in and assist. And with that, I'd love to stand for any questions that you guys might have.
Thank you. Committee, any questions? All right, thank you very much.
Thank you.
Senator Hutchings, sorry, Senator Hutchings.
Thank you, Madam Chair. Matt, I'm really glad you came on, because I listened to Mrs. Carroll's presentation, and I've worked with the pharmacist for quite some time, and I understand and know what your desire is. And I don't think, and I'm gonna believe the committee doesn't think, that the pharmacist wants to work outside of their knowledge, their skills, or their abilities. They have been given, some of them, special skills that could really benefit Wyoming and the rural area. So I'm gonna keep championing with you guys to get what you're desiring done, with hopes that the physicians aren't looking at the pharmacists as, we want to take over. No, we just want to assist where we can, where we've been trained, and in other words, utilize us if you can in these rural areas, so that you don't have to do the work. We can help do it for you. That's my take on what you're trying to do. Is that correct?
Madam Chairman, Senator Hutchins, always good to see you again. But absolutely. Again, you know, our training is not the same as a physician's, but it is still an extensive training that can help assist fulfill some of these gaps for the very common and chronic conditions that are just not being fulfilled right now. So yes, we want to assist in any way that we possibly can in order to improve outcomes, in order to improve patient access, health outcomes, reduced emergency room visits, longer life expectancies, without overstepping our training, our bounds, and again, like I keep mentioning, keeping the primary care provider, who is really the quarterback of the patient care team, appraised of the situations and in the loop at all times. It's not to take over as the patient's primary care provider. It's not to step on physicians' toes. It's to assist them, to allow them to focus on more complex issues and to improve access to patients that don't have a primary care provider, or their primary care provider isn't available or open at the hour when they're sick. If we take a look at influenza, for example, you need to initiate antiviral therapies within 48 hours of symptoms onset. That means you have to get into your physician, be seen, get a prescription ordered for Tamiflu or an antiviral, go to the pharmacy, get it filled, and that all has to be done within 48 hours in order for that treatment to be effective. That is someplace where just showing up at 11 o'clock at night when symptoms start, going to the pharmacy, getting swabbed, having that test ran, getting that treatment started can increase access, improve outcomes for everybody all around.
Thank you very much. Any other further questions, committee? Okay, thank you. I believe we have one more online. All right. Welcome. If you'd give us your name for the record and your testimony.
Yeah, my name is Bryce Habel. I'm a pharmacist as well, and I just kind of want to echo Matt and Melinda's testimony. And I'm in the same boat as Matt, and just kind of, we are team members of the healthcare team. We don't want to replace the primary care provider, but that primary care provider, he is a valuable resource in our communities. Our communities, they have these healthcare deserts and the great distances that travel to receive healthcare. And we as pharmacists have this drug training of knowledge of, how a med affects your blood pressure, for example. And we have the unique opportunity for that access. Like Matt was saying, a patient will see their pharmacist a lot more than they will see, anybody else in their community or their primary doctor. And patients, they can feel more comfortable coming to their pharmacist with a problem, with any way that we can help that patient have a better health outcome, is kind of where we're looking to expand our practice. It's not, we're not asking for anything that we're not trained to do. It's more to manage the medications effectively. We test for high cholesterol. We see that we're able to treat that. And our systems are set up that we can, fax the doctor, hey, this treatment was initiated. And we can be part of that collaborative health treatment. And that's where we want to be a part of, is that we want to collaborate with our primary care doctors, free up their time so that they're not dealing with, a simple cold sore or something where a trained pharmacist can deal with it instead. And that way the primary care providers, they can deal with the more complex cases. And the difference between, a clinical pharmacist and a regular pharmacist, that's a, like Matt was saying, it's a wide ranging thing where, the clinical pharmacists are dealt with to treat with the ICU type patients, and that's where the more complex cases. What we're really asking for is for our community pharmacists to help with simple needs that the community pharmacists are trained on how to do, and provide those primary care providers more time so that they can deal with the more complex cases. And that's kind of where the pharmacists in Wyoming would like to be at. With that, I just would invite any questions that you guys have.
Thank you, committee. Any questions? Representative.
Thank you, Madam Chair. Just a question on, are there any financial incentives that the pharmacies would want to go down this road? Do they have any?
For
benefit?
sure. And Matt can attest to this, and it's been brought before the legislature before. The pharmacies, as far as prescription dispensing through PBMs, it's been going down, and so having another revenue source, being able to bill through our own NPI medically would help sustain some of our smaller pharmacies and help them so that they wouldn't have to close their doors, and so they wouldn't have these healthcare deserts in our communities.
Thank you. Follow up?
Thank you, Madam Chair. So would you be in a position to begin recommending other medications if we were to expand this whole thing?
Yeah, I mean, it would be more, where the pharmacist is comfortable at. I mean, we're not going to, treat a patient who should be in the ICU. It's more of that patient that doesn't have the primary care physician, has been having symptoms, wants to know what their high cholesterol is, and help them manage that, help them manage their blood pressure. How many elderly patients do you know that go to their pharmacy just to test their blood pressure? And if that's high, the pharmacist is in a unique role so that he can help the patients manage that.
Other questions? All right. Any other questions, committee? Okay. Thank you. All right. Follow up.
Madam Chair, Representative Guggenmans, thank you for that question. I would like to say, is there financial gain? We unfortunately are not paid very well for dispensing medications. We don't make a lot of profit on those. And in the end, at the end of the day, what I want as a pharmacist is literally for you to be on no medications. That is my hope and dream for every single one of my patients. I would like to see them off of all treatments, if that is possible for that patient. And we like to see lifestyle changes and doing, things that are going to be best for them. So is this a way for us to push drugs? No. That's not our intent with this. Our true intent with this is to try and fill those gaps in those communities that we can see, that has been testified to, where we do see, the elderly patient that ends up in the ICU with sepsis because she was not able to get treatment for a urinary tract infection, something that's treated very simply and something that I would make absolutely almost no money on prescribing for her. However, it is filling a need for that patient and alleviating the primary care strain of our communities, especially the rural ones where these two gentlemen practice. They do have those smaller pharmacies that are accessible for patients to get to in those major need kind of situations. So we are not looking to push meds. That's not what we're here for. We are here to simply try and fill that gap that we can quite clearly see that we are trained to fill, but are not able to because of statutory language.
Thank you. Committee, any questions? Okay. With that, we are going to close public comment on the Rural Health Transformation Program. I believe we are only about an hour and 22 minutes behind. So I'm going to call that as a win for labor health. I think we're doing good. And I was not sure. I knew this would be a lot. I didn't know how much. So thank you, everybody who has been here and testified. We're going to go ahead and take our lunch break now. And we will come back at 2 and we'll take up the maternity care providers issue and behavioral health provider shortage after lunch. And with that, we are recessed for lunch.